Okay, everything looks good. Thank you very much, everyone, for joining me today. My name is Dr. Mahin. I'm from Bangladesh. So if you are following me on my YouTube channel, you usually don't see me or don't see my name or something like that. So today we are here to enjoy a little, not a little topic, but it's a large topic, So we are going to talk about the ultrasound basics today. Though I'm going to talk about the basics, but I won't go with the complex physics things because I will try to make it a little bit easier for everyone because many different faculty persons are also joining here. So I'll try to make it a little bit easy. So if you are connected to me, obviously you are connected through the Facebook Live. Please make sure if you make a comment, try to comment on the live video so that after the end of this session, we can solve all of your questions. So this will be a large session of around 3 hours. That will be a very long session, obviously. So I'll try to make you not getting sleep. So anyway, let's start with our ultrasound basics. Before starting, I would love to share my YouTube channel with you, naming Imaging Study. If you already know or already you are a subscriber, thank you for being with me in this long journey. And if you're new, you can obviously search Imaging Study on our YouTube, and you can get it there. So we have around 58,000 subscribers with 461 videos there. It's very difficult to upload videos right now. So the last video was uploaded around 1 month ago. So I'm very lazy about that. Hopefully, we are going to upload some cases in recent future because I have already quite completed my studio setup. It's a home studio and I'll try to upload videos regularly, hopefully. So anyway, let's start with our sound. You all know that sound is a mechanical energy that travels through a matter, producing some compression and relaxation. So these are the compression and relaxation. So it's a wave actually going through a medium. So it needs a medium to pass. And if you try to change the sound, it can be changed into different energy. So that is actually a topic which we'll talk in the bioeffects part. Now, we have an audible range. We can't hear all the sounds. So we have audible range of 20 to 20,000 hertz that we can hear as a human being. If you are animal, you can hear different sounds also. So we have another term named frequency, which is actually the cycles per second, which we use a lot because all the machines, when we use the term frequency, like this transducer using some frequency, that transducer using some frequency, and things like that. So frequencies are the cycles per second. And when we do the ultrasound, you have to understand the value of frequency. Like when you use the high frequency and when you will go for the low frequency. If you are trying to see a superficial structure, it's better to use the high frequency because when you are using high frequency, you are getting the best resolution. The benefit of high frequency is getting a good resolution. So we all want a resolution to be very good, but the problem is that when you are using high frequency, you are getting a good resolution, but the high frequency waves have a very low penetrating capability. So they just go inside the skin and get reflected. That's why you can't see the deeper structures. So when you are trying to see the deeper structures, you obviously have to use the low frequency. That's why different organs needs different frequency to see. Usually we use high frequency to see the superficial structures like thyroid, breast, testes, skin, eyes, anything like that. And when you are going to the deeper structures like abdominal structures or obstetric structures, you should go for the low frequency. But the problem arises that when you are using low frequency, you are getting bad resolution. So we try to adjust this formula at a level that we are using the low frequency, but we are getting a little better resolution. So we need to change it frequently. Okay, so now come to the ultrasound. Not all the sound waves are ultrasounds. There are some infrasound, there are some ultrasounds. So the frequency below 20 hertz are called the infrasound, and the frequencies above 20,000 hertz are called the ultrasound. So there are different uses of ultrasound. We have a separate video on our YouTube channel showing ultrasound uses, I think. So you can see different uses there. But for our medical use, we use specific values. So ultrasound is inaudible to human ear. That's obviously, and we are not using 20,001, 20,002 hertz. Actually, we are using very high frequencies for our medical purpose. And for medical purpose, we are using 1 to 30 megahertz. Make sure this terminology or this range is not static. It's changing every day. Like now, we are using 50 to 100 megahertz to see the eyes, actually, to see the antechamber during biomicroscopy. So if you're an ophthalmologist, you know better than me about this topic. So with the change of days, we are seeing that the change of frequencies are happening. So right now, it's very difficult to say that 1 to 30 megahertz is the only range for the diagnostic ultrasound. It will get changed. Previously, we tried to say 1 to 10 megahertz, 1 to 15, 1 to 20. Now we are telling that it's 1 to 30 megahertz, but make sure it will get changed. Okay, let me just check the Facebook video because if I'm just talking and there is nothing going on, it will be weird. Okay, so thank you for joining. So I need to close the. Okay, so now the question arises, why do we need these high frequencies? Like, why are not we using 21,000 hertz, and why we are looking at 100 megahertz, like mega, 10 to the power 6 equals mega? So why we need these high frequencies actually? So we'll talk about that a little bit later, but you already actually know that when we are using high frequency, we are getting better resolution, but the penetration is not very good. So when we're trying to see the eyes, actually the antechamber, even the cornea, we try to use our best high frequencies available. So that is the reason for using these high frequencies. And if you are using 21,000 hertz, okay, what do you want to see? You can't see anything there. Okay, so let's come to the ultrasound machines. We have three different types of machines, fixed one, portable ones, and the handheld ones, which you love quite. I know I also love handheld machines, but I can't afford it. So now come to the fixed type of machines. We commonly see these machines in our diagnostics and hospitals. So these are large machines and they have more functions. Obviously, so there are durable machines with a very good. They offer different type of transducers in a single machine. Like you can see many ports here for the transducers, but they have some disadvantages. Like they're just let me check my internet connection. Somebody's trying to call me, I think. So the internet may jump a little bit. Let me check it. I hope it's okay. Yeah, okay. So the main disadvantage of these high priced machines is that you can't afford it. It's quite expensive. So if you have a small diagnostic or you are trying to start a business of medical equipments, it's very difficult to manage this type of expensive machines. And they obviously take more spaces and they're not suitable for carry on. So if you are trying to take this machine to different area, like even if you are on the first floor and you are trying to go to the second floor, moving these machines is a little bit difficult because there are so many cables and it needs a very big space. So it's not suitable for bedside ultrasound practice or portable ultrasound test. So come to the portable ones. These are very good machines and very popular nowadays because they're good for the bedside ultrasound scans. Nowadays, many clinicians, as far I know, they use ultrasound for bedside practice, like for MSK or for interventions. So these are very good for them. And they're relatively cheaper, and takes a small space, actually. So they're very popular nowadays, but the main disadvantage is that you are not able to uh, get a very good software and hardware support here. Like you can't use multiple transducers. I have experimented on some machines. Like if you have a small machine and you try to use more than one transducer, the machine doesn't respond quite good. So it's better to use a single transducer for a single portable machine. So that's a very big limitation. Now, when I do ultrasound, I try to change transducer very frequently. So with a single transducer, the scan is not satisfactory for me. So I need multiple ultrasound transducers. So this situation is not suitable for the portable ones. Now, there are some software limitations also. These machines get slower by time usually. Uh, you know, uh, oh, this is 2024, and the manufacturers are making very beautiful, very expensive ultrasound machines. Like if you see my mobile phone, it has got, I think, 12 gigabytes of RAM. Usually nowadays, gigabytes of RAM for the gaming phones. And when we look at our ultrasound machines, manufacturers are giving us like 512 megabyte of RAM or 1 gigabyte of RAM if you are very premium person. So this is very weird. You should give very high RAM. You are taking very big money, so that happens for the large machines also, and for the portable ones. I even saw a machine with 64 megabytes of RAM. That was the lowest RAM I have seen in last, I think, 15 years. Okay. So again, these machines are not so durable like the large ones, and the resolution is obviously lower than the fixed ones. Now, what about the handheld ultrasound machines? These are getting very popular, and we can see the manufacturers are researching on these machines quite a lot. You see many advertisements are related to handheld ultrasound machines nowadays in different programs, different conferences. So they're more focusing on this type of machines. They have actually very big customers for this type of machines, but they have some limitations also. So let's talk about that. The main advantage is that it's extremely portable. Like a mobile phone, you can carry it on your pocket. That's very good. And obviously, nowadays we are focusing on point care ultrasound, and this thing is a very good tool for that. Now, the main disadvantage is that it has a very limited functionality as till today. And obviously the transducer support is very low, and it's quite expensive. Like you're paying a lot to get a small thing. um it's very expensive. And obviously some manufacturers are taking monthly subscription fees, which is very weird. I'm paying all the money to buy a machine, and it's not mine. Okay, so hardware is mine, but the software is yours. So that's quite weird. So you need monthly subscription for many machine manufacturers. That's not good. Okay, it's still less durable, and obviously the resolution is still not very satisfactory in comparison to other ones. Like with this machine price, you can obviously buy a very good portable machine. So that makes the market very loose, and hopefully it will get upgraded soon. Anyway, so my question is that nowadays handheld ultrasound machines are very widely used. Especially I saw cardiologists using these handheld machines for their patients' echocardiography on the bedside. Like they're carrying this on their pocket. Now, the question arises that can handheld ultrasound machines really defeat the stethoscope in the future? Well, we will see that. What do you think? Tell me on the comment section below. So before buying an ultrasound machine, you should obviously think of several points. I have a separate video on my YouTube channel giving 5 important tips if you are trying to buy an ultrasound machines. So I won't go with these points actually. So you can actually check those that video and you will get some very important points. If you're just a regular customer, before buying an ultrasound machine, take my tip. The the seller will always show you the liver of the patient or his own liver and will show you that, oh, this is a very good machine. See the resolution. Nowadays, each and every machine can show you a good resolution of liver. So always try to see the lower abdominal structure with your machine, which you want to buy. Like if you go for the uterus, or if you have a prostate, you go for the prostate. You see the resolution. If the resolution is okay, then the machine would be okay. If the resolution is not okay, then before buying that machine, you should be a little bit careful. If you're a Doppler practitioner, obviously the seller will show you their own carotid vessels and they'll show you, oh, there is a very good color there. All the machines nowadays can show you a good carotid artery, but this is not what you are using. So if you're a person who's doing color Doppler, you see when we are trying to visualize the renal arteries, it feels very difficult. So if you are trying to buy a machine, try to check the renal vasculature and try to obviously to check the spectrum of the renal and intrarenal arteries with that machine. If it is good, then the machine should be good. So that's the simplest tips about buying an ultrasound machine. But for more details, you can obviously search my video on about 5 important tips before buying an ultrasound machine on Imaging Study YouTube channel. So I'm promoting a little bit about my channel. Anyway, so come to the transducer, which is the most important part of an ultrasound machine. And this is the functional part actually, which converts the electrical energy to the mechanical energy and obviously vice versa. So it has 2 important functions, like it acts as a transmitter. It transmits the sound wave and it receives the reflected echoes back. So when it gets the reflected echoes, it transfers or converts it into the electrical energy again, which is now processed by the machine and we can see it on as an image. So the main active person is the transducer. If you don't have transducer, what will you do? So you have nothing to do. You need a transducer to do the ultrasound actually. So transducer have different components. I won't go with every part. Every part has their own mechanisms. I think you are not here to know the use of housing strong plastic. So the main component of an ultrasound machine, which I want to discuss, is the piezoelectric crystal, which is the main functioning part, which is changing the electricity to sound and sound to electricity. So this is the piezoelectric elements, which is the most important component of an ultrasound machine. So the main principle is about the piezoelectricity. We have heard about this in our physics class, I think, when I was in my school, I think, or something like that. I have heard about that. Anyway, so the transducer is the most expensive part. So before falling it down, you should be a little bit careful. You should know the price of your transducer before falling it. Now, about the piezoelectric mechanism, it was invented by or described by the Pierre and Jacques Curie in 1880, actually. So the piezo comes from the Greek word and it means to press or to compress or to squeeze. So this is the main component of the transducer, which produces the sound or diagnostic ultrasound. So the main mechanism is that we are giving a pressure and that pressure creates the electricity. So the electricity is coming from the pressure, which is coming from the reflected sound of the patient's body. So this is the last point, I think. So the first point should be putting the electricity. So we put electricity which has been generated from our machine. So this electricity comes to the transducer surface, to the piezoelectric crystals. When you give piezoelectric crystals some electricity, they make some vibrations, like some mechanism of cations and anions. So I won't go for that. So there will be a vibration, and this vibration will create the sound. This sound goes to the patient's body, gets reflected from the body parts, and come back to the ultrasound transducer. So have you seen the waves from the sea or from the river? When they comes, they give you a pressure, like you are in the middle of sea and there is a big wave coming to you. And when they come and touch you, you feel a pressure. So these sound waves also create some pressure. So this pressure is then converted into electricity. And this is the mechanism of piezoelectric crystals. And this is called the piezoelectric effect. So what we are actually simplifying it, what we actually are doing is that we are putting some electricity, making sound, getting reflected sound, and changing it to electric signal, and then drawing an image from this electric signal in our machine. This is the basic mechanism of all ultrasound machines. Nowadays, we are using lead, zirconate, titanate as piezoelectric crystals. There are so many piezoelectric materials, like naturally occurring quartz, obviously this one. And the artificial one is very popular, a piezoelectric crystal, that is the lead, zirconate, titanate. You have many different options also. So now come to the transducers, the most valuable types of transducers. There are so many of different price range. And obviously, if you look at a single transducer, like this one is the sector or phased array transducer, it has many different variety by many different manufacturers. So when you are getting one, you should be a little bit careful about the frequency range of that transducer and what you need. Usually machine seller will try to describe you about their different transducers before you buy it. Anyway, first come to the sector or phased array transducer. They have an interesting property, like they produces sound from a single point. So this is called the sector transducer. So there will be a narrow starting point and they will go like a fan shape pattern. So this is a deeper viewing transducer. So we will use low frequency here, like 1 to 5 megahertz commonly used to see the deeper structures, obviously. And we use it for the echocardiography or cardiac ultrasound, for lung ultrasound, transcranial ultrasound, and even you can see the abdominal structures through the intercostal spaces with this transducer, as it can send from a very single point. So if you want to see anything through a small cavity, this transducer is the best one. Like if you put here above that air, anterior superior to your ear, you will see there is a temporal window, very small opening. Through this opening, you with the sector transducer, you can see your circle of Willis, maybe. Don't forget to check that. I can see my circle of Willis with this transducer. Okay, so the sector transducer has a very big advantage of having a very small footprint, and it can put the sound through a very small orifice, which is a very big benefit, especially if you're doing cardiac ultrasound or transcranial ultrasound. But the main disadvantage is that it is a low frequency transducer, and obviously it has a poor resolution in comparison to other transducers. And also, if you want to see the superficial structures, obviously this transducer is not the good one. Now come to the linear one, which has got a very good resolution, especially because it has a very high frequency, and it may have different frequencies depending on which transducer or which type of transducer you are using. Like it has many different types. Some are from the musculoskeletal ultrasound, some are good for the vascular ultrasound. So it depends. You should be careful before buying it. Now, it has a big range of frequencies available in the market, like 5 to 12, 12 to 16, 18, or 15 to 20, many different range and many different types. So it has a flat footprint or flat surface, so it produces sound like a straight parallel lines. And using high frequency, it is very good to see the superficial structures like thyroid, breast, testes, vascular system, musculoskeletal ultrasound, skin ultrasound, ophthalmic ultrasound, many more. We also use it for the ultrasound guided superficial procedures like biopsies and vascular access also. So this linear transducer is very good to see the superficial structures. And as I do many vascular ultrasounds daily, this transducer is quite like my best friend, something like that. Anyway, main disadvantage of this transducer is that it cannot help you to see the deeper structures. So when you are trying to see the deeper structures, you definitely have to shift to another transducer. And to see the deeper structures, the most common transducer is the curvilinear or convex transducer. So curvilinear or convex transducer has definitely, with its name, it has a convex surface and it produces sound waves like a fan pattern, and the sound goes very deeply. So we'll use low frequency here to see the deeper structures with a good resolution. So we use this transducer for any abdominal or obstetric ultrasounds, definitely because we are using low frequency, so we can see very deeper structures with better resolution, I think. We also can use it in musculoskeletal and soft tissue ultrasound. Sometimes I have to use this for even to see the popliteal artery, which is very superficial, but the patient comes with a very obesity or a very edematous condition. So I have to use this to see that even the superficial structures, though it was not superficial at that time because of this edema. We also can use it for the intraoperative ultrasound. Anyway, so this is the most common transducer we use. It has a very big advantage of a combination between the combination of sector and linear properties. Like it can show you the deeper structures like sector transducer, but its surface is quite wide, so it can be a part of linear variety also. Anyway, the main disadvantage, yeah, it has a large size. So if you want to see the structures through the intercostal space, it may not be very comfortable, and you will touch the ribs and there will be hazards there, which we'll talk in the artifacts part. Now come to this, depending on these three types of transducer, we have some advanced transducers which we use, like transvaginal, transrectal, 3D, and many different transducer. So come to the transvaginal transducer or TVS probe. This is an endocavitary probe we use for transvaginal sonography. Don't use this transducer only for the transvaginal ultrasound. Like when I have a patient with acute pancreatitis, acute appendicitis, and I can't see the appendix quite well with my linear transducer. I use this transducer also, but not through the vagina. I use it through the para-abdominal approach. Like I put the transducer over the McBurney's point, I put a little pressure over there, and I can see it in a very good resolution. So it's actually a type of curvilinear transducer using the frequency of using high frequency of linear transducer. So it's a combined probe. That's why you can use it for many different purposes if you are very clever. We also use it for transrectal ultrasound if there is no transrectal transducer available, which is very common in my country. I don't know about your, so don't forget to tell me about what happens in your country about the transrectal ultrasound. Now, I also use it for the transoral ultrasound. Sometimes people come with oral cavity lesions, like tongue lesions or some cheek lesions. I use this transducer. It's very comfortable to see those structures with this one. So it's widely used for the obstetric and gynecological purposes, actually, but I want to tell you some different aspects of this transducer. Now, the transrectal transducer is also used for the transrectal ultrasound, and but unfortunately, I don't have this transducer. I have to do with the transvaginal one. It has some differences between the shape, I think. So the shape is quite different. It's quite straight. And it's also very good for the biopsy purpose also. We have the 3D 4D transducer for the volumetric images. They also have the linear, curvilinear, sector, and TVS TRS varieties available. And they're very good for the volumetric, beautiful fetal face images. We'll talk about this 3D. A long session will be available at the end of this lecture. Okay, next come to the transesophageal transducer. We use this transducer for transesophageal or upper GI ultrasound. It's quite similar to the upper GI endoscopic procedures, and we also use it for the transesophageal echocardiography, which is the best echocardiography, I think. Okay, so endobronchial transducers are used for transbronchial ultrasound. You can adjust the biopsy needle with that to catch the biopsy material from the desired lesion. We have the intravascular transducer of different varieties, obviously, to do the intravascular ultrasound. And you can see the vessel wall and assess it and do the proper measurement using this transducer. We also have the intraoperative transducer, obviously of different varieties, depending on which type of surgical procedure you want to do. Usually, our centers have this type of acoustic transducer. This is known as acoustic transducer. This is a type of linear variety to assess the patient perioperatively. Okay, so these are the transducers available in my center for doing the ultrasound. I have 4 transducer attached. I think I have another one. 1, 2, 3, 4, 5. I have another one, 5. Which one is missing? So the linear one is missing. I missed the picture. Okay, anyway, so I have actually 4 curvilinear variety of transducer here, which I want to show. So the first one is C29. This is a G machine. G is not sponsoring this program. So not avoid them. They have a good machine. Okay, so G machine has different type of transducers available. Now this machine has C290, which is very good transducer to see the fetal heart. I commonly use it for the pediatric ultrasound. It gives a very good resolution. This is the common transducer like C16. This is the popular curvilinear transducer. I have the 3D transducer, which is the RM7C name. This model is very good, a little bit expensive, obviously, but it gives a very good resolution. So I use it for the fetal echocardiography also, not using this one because this 3D transducer is very lightweight, not like other bulky ones, and it has a very good resolution. So for obstetric scans, I highly recommend this transducer. And this one is the TVS probe with the 3D functionality here also, and it's also very good. Okay, before going to the next slide, I will just check my Facebook Live if there is any question. Please, if you are watching this video from any different Facebook group, try to just post the comment in the live video so that after the end of my session, I can solve your questions. Okay, thank you. So now come to the transducer. Before using the transducer, you should be a little bit careful. I always tell my student that don't hold the transducer like a knife. Like you are holding it like this and going to your patient like this, patient will get afraid. Okay, so it's not a knife, okay? You are not killing the patient. So try to hold it with your hand like a pen. It's a pen. So you draw beautiful pictures of the patient. So hold it like a pen. And when you're holding it, you should be a little bit careful. So the transducer has this surface. This is a curvilinear transducer, and this surface is coated with a rubber coating, and inside it, there is a piezoelectric crystal layer, which is producing the sound. So when you are using this transducer, you should be very careful. Don't put it down. And if you just broke it, you have to pay a lot. So be careful about the transducer. Uh, I have a little experience actually about just putting the transducer down onto the surface from a very big height. And I know which ultrasound machine manufacturers can produce very good transducers, fall-proof transducers actually. So I won't share it here because nobody should experiment that. Okay, so the transducers have a portion, pointed portion, which is called the indicator. It is important to put the indicator in proper direction to understand the orientation of the picture. So when you are holding the transducer, you are holding it in a transverse section. We commonly do the indicator, we put the indicator to the right side of the patient. If you're putting it to the right side of the patient, the screen orientation comes like this. The upper part will be always anterior because we are putting sound from the anterior to posterior aspect of the patient, unless you are doing it from the back side. And the right side of the skin will be the left one, and left side of the screen will be the right one. So that's a little bit confusing. Don't get confused. If you are putting transducer transversely and putting the indicator to the right of the patient, you see this point here, G, again, you are not sponsoring this video. So if you are putting it, if you are looking at here, this pointed part or this marking is actually indicating the indicator side. So if you are putting it to the right of the patient, this side will be right. If you are holding opposite side, then this will be the left. So whatever. So this indicator point is marked with this part. So just make it simple. So now I'm holding the transducer longitudinally and putting the indicator towards the face of the patient. So this indicated portion should be the face of the patient. That means this is the superior part and this will be the inferior part. But the upper and lower part is always anteroposterior because we are putting sound from the anterior side of the patient to the posterior side. Okay, so the indicator is the indicator. So wherever you touch, wherever you hold it, depends on you, depends on your style. But the main principle is that you should understand which one is the right and which one is the left of your patient, so that you are not making any confusion. Just don't make it very much deep. It depends on you, whatever you want. Okay, anyway, come to the ultrasound gel. We use gel a lot, okay? So this is a fluid media we use and it's quite like a semi-solid substance, I think. So this gel is composed of water actually. Most of the part is water and there is EDTA and something else. So it's quite safe. It doesn't actually irritate the skin surface, and the main reason to use the ultrasound gel is to prevent the air. You know, we have two enemies while we are doing ultrasound. The first one is the air. Second one is the fat. So if you are obese, please reduce your fat before coming to us. So the air is very big notorious substance for us. When we are holding this transducer to my skin surface, you see there's some airs in between these two surfaces. So air has a very bad notorious property of just distracting the sound. So it will, like a microphone or mic or speaker, the sound will go here and here, but not entering into my body. So we want all the sound to enter into our body and get reflected back and received by this piezoelectric crystal. So we don't want it to get to any other place. So we put a gel in between so that the media is continuous. Now the sound will go enter into our body and then will get reflected. So the main principle is to avoid air. Now, when we are talking about avoiding air, so why we are using this gel? Like the most of the component is water. So why we are not using water? Now, we used water actually. This is a very old picture when people had to just put into the water drum, and then we did the ultrasound. So it's quite weird, but nowadays we don't want to put a pregnant lady to a water drum and do some ultrasound. So the main reason of not using water is that water will evaporate from your body and you can't hold the water into the body. It will just move along the gravity. So it's quite disturbing to put water every time you are doing on the ultrasound. But it can be used when the gel is not available. Like I'm giving you a tip. When the patient comes to me and I have to do oral ultrasound, at the time, sometimes if the patient is baby and I just put a slip of water here over the transducer surface and then I put it over the tongue. That will be very simple. So you can use water over this surface, but it's not commonly used. Okay, now the next question is that why we are not using oil? Oil can be also used. It's also a liquid or semi-solid substance and it will not go away from the body. It won't get evaporated. Well, okay, but in long time, oil will damage our machine. That's one property. And another one is that if you put oil, it will cause a stains over the cloths. So we won't, we don't want to put a stains to the cloths of patients. So we won't use oil. We love our gel. This is very safe. This is very much available throughout the world. So we'll go for the gel. Don't use water over the patient. Let's go for some terminologies now. So we have a very small talk about these terminologies. I won't go very deeply. So we have some points like acoustic impedance. Impedance means the resistance, like resistance of sound when it propagates through the media. So there are some calculations. I won't go for these calculations and won't make this physics complicated. So the acoustic impedance actually depends on the density of the media and the speed of the sound in this media. So that is very important when you are dealing with ultrasound. Each and every media has different density. Each and every media has different speed of sound. So acoustic impedance is not similar for each and every media. So here comes another term like this, which is quite similar but used in a different way. That is the attenuation. So when you are giving an impedance, the ultrasound or the sound gets weakened. This property is called the attenuation. So due to impedance, when the sound gets weakened, we call it attenuation. There are 6 different interactions that are responsible for attenuation of ultrasound. So we'll talk about all of this, which are actually making our sound very loose or weakened. So this weakening is very important because with this weakening and this change, we can diagnose many different abnormalities. So the main important thing is the water doesn't create any attenuation. It has an attenuation value of 0, so it won't disturb and the sound will go very smoothly without any impedance. Like for the soft tissue, there is some attenuation and air will cause a huge attenuation. Bone, you know that bone reflects all the sounds, but air is more notorious with a very high attenuation value. That's why we don't like air. Okay, live a life without air. Now come to this attenuation properties like absorption. You know the absorption. I don't have to say anything. So when the sound go to a media, it may get absorbed, and this is the point where we think about the bio effects of the sound, because if it gets absorbed, it will get changed to the heat. So there will be a heat production which may cause clinical issues. Now, we know the reflection when the sound goes and comes back to the transducer, we call it the reflection. That is the echo. Sorry. Now, what about the scattering? When the sound goes to a surface and gets a new direction, so this redirected or sounds in several directions is called the scattering. Air is a notorious substance for that, or fat is another substance doing this thing. So what about the refraction? Refraction is changing a direction. Like when it is changing the media, it is changing the direction. We call it refraction, which may cause some artifacts also. Diffraction is the spreading of the beam that occurs after a tiny focal zone. So sound was going like this, and after a single point, it is just getting dispersed. This is spread. This is called the diffraction. Now, what about the interference? When two types of sound, two different frequencies or two different waves are meeting each other and making a new wave, this is called the inference. So this inference will also cause some artifacts, which we use during the lung ultrasound, I think. So we have other terms like acoustic window. This is very commonly used term in ultrasound. You'll see on the report acoustic window type term. Like this is very simple thing. We are using one tissue or one structure to see another structure. So this is the acoustic window. Like when you are doing a lower abdominal ultrasound or pelvic ultrasound, you see, we tell you that you should have a very good filled urinary bladder. Why you need a urinary bladder to be filled? It's because if you fill the urinary bladder, we can use it as a window. So using this window, we'll try to see your uterus, prostate, or any deeper organs. Similarly, with the liver, using it as an acoustic window, we try to see the right kidney. So these are called the acoustic window, using one structure to see another one. Now come to the ecotexture. So you see some points like ecotexture, echogenicity. So ecotexture is of two types, like homogeneous or heterogeneous or inhomogeneous. So homogeneous means all looks same, similar shades of gray. This is not 50 shades of gray. So heterogeneous or inhomogeneous means different shades of gray in a tissue, like different texture. So here you can see all part of the liver looks quite similar, but here you see the parenchyma looks different. Like this area is dark, this area is light, something else going on. So this is the homogeneous pattern with similar pattern. This is the heterogeneous one with different pattern. Now come to the echogenicity. We describe echogenicity a lot. This is the term used to describe any normal or abnormal structures. So it is like the brightness. So brightness term is used for the light. We use echogenicity for the sound. Otherwise, it's quite similar. So this is the transmitted sound, which we actually reflected sound. We put it into the image category or image-like appearance. We use the echogenicity term. Anyway, so echogenicity is the similar to the brightness. So we have some dark areas here. We have some bright areas here. So we will say that this area has low echogenicity. This area has very high echogenicity. So that's the thing. Okay, now come to the point how we actually describe or what are the echogenicities. So think about this structure. We are putting sound over it and sound gets transmitted through these structures, and some sounds get refracted, so change their direction. Some gets absorbed and some gets reflected. So this reflected sound is called the echo, and we put it into the image or convert it into the image. That's why we don't want to call it brightness, we call it echogenicity. So for the sound, we'll use the echogenicity term. So some structure is having very good echogenicity or high echogenicity. We call it hyperechogenic or hyperechoic or echogenic. Some has a very low echogenicity, so we call it hypoechogenic or hypoechoic. So when you are trying to say hyper or hypo, there should be a standard one with which we can compare. So for the abdominal structures, we commonly, or for the ultrasound, we commonly use isoechoic or isoechogenic term for describing the liver parenchyma. So normal liver parenchymal brightness, this brightness is quite familiar to us, or you will get familiar to it. So this this brightness or echogenicity is called the isoechoic. Make sure if you are trying to describe any other structure comparing to anyone, you can also use echogenic term for a different one. Like when I'm telling a thyroid nodule and I want to say this thyroid nodule is hypoechoic, I use the isoechoic term to describe the normal thyroid parenchyma. So you can use it for any different organs, but when we are saying isoechoic, it indicates that we are targeting to the normal hepatic parenchymal echogenicity. Okay, so this is the isoechoic. So if the structure is more bright or brighter than the liver parenchyma, we'll call it hyperechoic. If it is having a less echogenicity, so we'll call it hypoechoic. So if you compare the renal parenchymal echogenicity, it's slightly reduced than the liver one, so we'll call it hypoechoic. Okay, some structures doesn't have any echogenicity. They look quite black. So this is the isoechoic, and you can see this one is the hyperechoic bright area. And comparing with the hepatic parenchyma, the renal parenchyma has a low echogenicity, so we'll call it hypoechoic. Now come to the anechoic. So we told you that the sound comes to the patient's body and it gets refracted, it gets absorbed, whatever. If it happens like this, like all the sound beams are getting transmitted, no one is getting reflected, so you won't see any returning echoes now. So if there is no returning echo, the structure will look completely black on ultrasound, and this is called the anechoic. So anechoic means there is no reflection of sound from that area. So this is called the anechoic or pure black. Usually crystal clear fluids cause no reflection of sound. Sound completely transmits through this. We told you that the water has a very low attenuation value of 0. So water doesn't reflect any sound or creates any attenuation. So it comes as an anechoic structure. So here you can see the urinary bladder, which looks anechoic. Here is my blood vessels, which doesn't have anything to reflect the sound, so it looks quite anechoic also. So we have completed the echogenicity part. We have 4 different echogenicities: anechoic with no echogenicity, like blood vessels, fluid, whatever. Hypoechoic means the echogenicity is lower than the hepatic parenchymal echogenicity. Isoechoic means it has the similar echogenicity of a normal liver, and hyperechoic means it has increased echogenicity in comparison to the hepatic parenchyma. Okay, so now the question arises about these echogenicities, like why these different echogenicities? Why is liver looks isoechoic but the diaphragm looks echogenic? Why is the renal parenchyma slightly lower echogenic than the hepatic one? Why this different type of echogenicity happening? So the formula is that very easy formula, that if the structure has more density, it will reflect more sound and it will be brighter and on ultrasound. So you are, if you tell me why the diaphragm is more echogenic, it has more density. So this is not the main physics mechanism, but it's easy to remember. Like you are looking at a lesion in the abdomen, you're looking at a mass with an echogenic pattern. So you should think about that it comprises of any highly dense structures within it. So more the density, more the reflection, and you will get more brighter structures. So let's make a summary here. So this liver echogenicity is called the isoechoic. This is the diaphragm, which is brighter than the liver, so it is hyperechoic. You can see anechoic gallbladder, portal veins, hepatic veins, and so many things. Even the screen is anechoic because they are not reflecting any sound. Here you can see the liver in comparison to the renal parenchyma. Liver is quite brighter. So we can say that a renal parenchyma is hypoechoic. So these are four different terminologies we use to describe any structures. So now come to the gain. So gain is called the strength of reflecting echoes. As I'm using microphone, I can increase the gain. If you are having a microphone and making songs, you see, if you increase the gain, it will disturb the audience. So like if I shout right now, I don't want to do that. It will create a very big gain. So this is nothing but the strength of reflecting echoes. So in case of ultrasound, if we try to make it easy for you, gain is the similar to the brightness adjustment. Like if you increase the gain, the picture will get brighter. If you decrease the gain, picture will get darker. So there is a gain button in your machine, like in my machine, this 2D option. If you rotate it in any direction, the gain will get increased or decreased. Like let me show you an example. Here you can see a uterus and ovary. It is high gain, like it's very bright picture. We don't want to see it like this. So I have reduced the gain. So when I reduce the gain, the picture looks completely dark. So this is not a good picture for me. I want to increase the gain a little. So when I increase the gain a little, now I can see the picture quite well. So it depends on you. For each and every structure, we need to change the gain probably. So this is a very common button we use in our daily life. So sometimes changing the whole gain, changing the whole screen brightness is not quite suitable. You know, when the sound passes through the media, it gets attenuated. So when it go to the deeper part, it's very difficult to see the deeper part because already all or almost all the sounds have reflected, absorb everything. So you will get a very small amount of sound at the deeper part. That's why it's very difficult to see the deeper part, and the image will come darker. Now, to see the deeper part, we need to increase the gain at the deeper area. So for this purpose, to change the gain at different parts of the screen, we have the time gain compensation option that is called the TGC. You see in your machine, there are some buttons here. I see people playing with these buttons, and these are the most common buttons to get destroyed or not functioning in a machine very frequently, because the doctors are very depressed, so they just change it for playing games, and like they do like this and they destroy or damage the button. So don't play with these buttons. Okay. So we rarely actually change these buttons unless we are looking at a very deeper structure which we can't see. Sometimes I need to change it by layers also. So we use this button or TGC option to change the brightness or gain at any level of the screen we want. This is the time gain compensation or TGC button. So when we are talking about the layers or depth, now come to the depth option. Always try to adjust or change the depth accordingly. If you need it, you should change it. Like I saw people taking the kidney pictures like this. Oh, you are seeing the kidney here. Huh? This is a very good kidney. Now tell me, what are you trying to see in these long areas? Can you see anything here? There is nothing there. So you don't need to see these whole structures using a very big depth picture. So always change the depth and try to make the picture more larger and very good one, like this one. Like here you can see I am showing you a prostate. It's a very good prostate. You always see prostate like this, but you should try to magnify the image using the zoom or depth option. So now you can see more details with the transabdominal ultrasound. If there is any lesion out here, you may see a little better. So let's try to change the depth. This is one of the worst habit for me. I change the depth quite frequently. So I'm worried that my machine may get disturbed or the depth button may get disturbed. Okay, now come to the focal zone. When you are trying to capture a picture with your mobile phone, you try to press the screen to adjust the focus. Okay, so similarly, we have a focal zone option to make a focus on that area. So this is called the focal zone. In the screen, you can see there is a pointed area here and here. So these are the focal zones. If you need focal zone, you can use multiple focal zones in your ultrasound machine, but try to avoid that because they will cut the frame and make your machine a little bit slower. So we usually try to use single focal zone to see the structure. And you need to adjust the focal zone. Like I'm here using 3 different focal zones, but I have nothing to see here because I'm looking at this vessel. So I need only one focal zone at that part to make the best resolution of that part. So focal zone is used just to focus or give a good resolution at that part. So here I'm using this focal zone at the level of the fetal middle cerebral artery, and you can see the middle cerebral artery here. So to see the best resolution and to get the best result on Doppler with this part. Okay, now come to the artifacts. In case of ultrasound, we always don't see the real things. We sometimes may see the false images and like this mirage. I don't know what you call in your language. We call it morichika. This is called a mirage. You see the movies where you see the this type of deserts where people see water, but there is no water. We call it mirage. Now this is an artifact. Like this is not real. This is happening due to different effects, physical complex things of the light. So similarly for sound wave, there are some artifacts which actually are not normal structures, but using these artifacts we can visualize many normal structures. We can diagnose many abnormalities, and even sometimes we may get disturbed by these artifacts to see the normal structures also. So let's talk about some of the small or important artifacts. There are so many artifacts. I won't finish all of this, but I will give you an idea. So come to the acoustic shadowing. So acoustic shadowing means shadowing. Acoustic term is used, I think, for the sound. Okay, so there will be sound shadowing, something like that. Now think of that when think about of a stone or calcified structure. So calcified structures are highly dense. Okay, we know that when you are putting sound to a highly dense structure, sounds will get highly reflected. Okay, so when we put sound over the stone or calcified structure, we see all the sounds get reflected. That is not a true. Many sounds get absorbed, but for this purpose, I won't share that. So all the sounds are getting reflected. So there is no sound below this stone or passing through this stone. So there is no sound here. Now, we know that if there is no sound, there is no reflection, that part should look anechoic on ultrasound. So on ultrasound, this posterior part of the stone will look echo-free or anechoic because there is no echoes here. Now, this part has not that density to show like anechoic, but this is happening due to the stone, which is causing reflection of all the sounds. So this is called the artifact known as acoustic shadowing. So we use this acoustic shadowing term frequently to describe calculus or stone. Like here, you can see the gallbladder is having 3 stones. These stones are reflecting all the sounds. So there is no sound passing behind them. And so you can see some black shadows coming behind this stone. This is called the posterior acoustic shadowing. This posterior acoustic shadowing is helping us to detect stones within this gallbladder. Now come to the acoustic enhancement. This is another artifact which we commonly see during our scan. So let me think about a fluid field structure. Think about this structure as a fluid filled one, and there is a solid part behind that. So we are putting sound over a fluid field structure. We know that sound doesn't get attenuated into a fluid field or crystal clear fluid containing area. So all the sounds will get passed through these fluid field structures. And after getting past, there will be a solid part. So you are just running through a part, like in my room, I will run here. Air won't prevent me to run, but there is a wall over there. So if I just go and think that I can pass through this wall, so I'm running there and I will get just knocked out there and will get back. Same thing happened for the sound beam. So getting fluid, they are just running away. But when there is a solid part coming behind that, they got reflected too much from that part. So this is happening due to the fluid field structure, which is giving them a platform to run faster, but getting reflected after this fluid field area ends. So the later part will show very high reflection of sound. We know that where there is very high reflection, there is increased echogenicity. So this part will show increased echogenicity. So this echogenicity is not due to the density of this part, but it is happening due to the fluid field structure, which was entered to this structure. So this artifact is called the posterior acoustic enhancement. It is happening because of this culprit urinary bladder. So you can see this is the urinary bladder, fluid field structure, sounds are passing through it. And after getting a solid part behind this fluid field area, they're getting reflected too much. So making it as a hyperechoic area. So this is called the posterior acoustic enhancement. It is quite like a light bulb. It is giving us a very good light. So this light is called posterior acoustic enhancement, and we can use it as a torch to see different structures, like we use it to see the uterus, prostate, or many different structures behind that. Okay, now come to the mirror image artifact. We commonly see it while we are doing the liver ultrasound. We can also see it through the linea alba and many different things. So mirror image artifact is that when the sound gets reflected from a highly reflective surface, this incidence happens. So I won't go with the complex physics things, how it happens. It's like a mirror thing. So you know about the mirror. Mirror is a complete piece of glass, but behind that, we make a separate layer of silver or something like that, which actually causes a highly reflective surface, and that makes the similar picture what we see in front, we see it behind. That is the mirror thing actually. So in case of liver, the similar thing happens. Like when we are scanning the liver, when the sound passes through it and gets reflected from the diaphragm acts as a layer of silver or mercury, whatever you use. So there is no mercury over the diaphragm. The mercury is over the mirror. So we are comparing it with the mirror thing. So the diaphragm acts as a mirror at that part. And for this reason, if you look here, above the diaphragm, there should be lung tissue, but you are not looking at the lung. You see, the texture is quite similar in these two areas. So you are actually watching the mirror image of the liver here. So this is called the mirror image artifact. So when you are putting the visceral pleura or parietal pleura, whatever, so when you are putting the pleura with the diaphragm, this two surface makes a mercury-like thing or mirror-like thing. So it creates the mirror image artifact. Let me show you. So here you can see the diaphragm, and this is the liver. You can see the similar texture, similar blood vessels here. So this is the mirror image artifact. If you remove the mercury or silver from the glass, it won't be a mirror of now. it will get changed to the glass and you can see the posterior part. So similar thing happens here. If you remove the pleura from the diaphragm, now there is a space over here and you won't see the mirror image artifact again. So let me show you a case of pleural effusion. Now you see my visceral pleura has got removed from the diaphragm. So now here is a pleural effusion and I can see the pleural effusion because there is no more mirror here. Now it is appearing as a glass. So mirror image artifact actually helps us to exclude pleural effusion or to detect pleural effusion. Like another case, let me show you. Here is a loss of mirror image artifact. So it indicates there is a pleural effusion going on here. So mirror image artifact may help us diagnose cases. So we have some other unimportant or less used artifacts also, like reverberation artifact, which we see at the front part of the urinary bladder. It happens when the sound gets reflected in a surface which has multiple layers like thing. So sounds get reflected and gets back and again reflects. So this type of artifacts happen and you will see the urinary bladder will show some straight lines entered to it. So this is actually the reverberation artifact. So if you reduce the gain, decrease the brightness, you will see that this refraction, this reverberation artifact will get lost. We have another artifact named age shadowing. It is happening due to the refraction of sound. So it happens when you see a cyst or you are looking at a gallbladder or a round surface. So from the edge of round surface, sounds get refracted. So there is a change of direction. So there is a lack of echoes from this part, which is creating an unusual echo-free line. So you can see shadows coming from these edges known as edge shadowing or refraction artifact. So it may make you confused about having gallstones there. So be careful. Any edge casting post-acoustic shadow may be due to the edge shadowing or refraction. We have another reverberation artifact type known as a ring down artifact that we see as a line coming from the air-like surface. So we commonly see it from the bowel gas. This is called the ring down artifact. We also see it during the scan of lung. So we have a tiny a reverberation artifact known as comet tail artifact. So a comet, if you are from Singapore, on the air, on the sky, you can see the comet right now, I think. So I missed that. So cometal artifacts are usually casted from any pointed structures like biopsy needle from any pointed part of the gallbladder wall in case of adenomyomatosis or cholesterolysis, or from the colloid particles within the colloid nodule of goiter. So, or from the nodule. So these are the comet tail artifacts, pointed tiny reverberation artifacts. We have another brother of comet tail artifact known as twinkling artifact when we put the color Doppler. So this is the color comet tail artifacts, a mixture of colors from the similar type of pointed structures. We commonly try to see it posted to tiny calculus from the kidney or from urinary bladder. You can see here a tiny calculus impacted at the vesico-uretary junction. It is not casting post-acoustic shadow because it's a very tiny structure. So the sounds are getting passed through it. But when we are putting a color Doppler, you can see a mixture of color here. This is called the twinkling artifact. Okay, so I use it quite a lot to trace the uretary calculus. It's very difficult to search the uretary calculus. So I put the color Doppler and try to search. So when there is a twinkling artifact, I pause there and I try to search for this stone over here. You can see this uretary stone is moving actually. Oh. So now come to the modes of display. If you are feeling tired, don't be angry at me. This video will be saved, I think saved on the Facebook, and I will also try to upload it on our YouTube channel. So you can also go there and see the recorded content, but make sure the question answer session, for the question answer session, you have to be here. Let me just check the Okay, thank you. Let's start again. So now come to the modes. So we have many different modes and the number is getting increased day by day. So we'll talk a little about these modes, but I will take a long time for this Doppler and 3D 4D mode. So come to the A mode. This is quite obsolete right now. Nobody uses it. So A mode is A for amplitude. So here the formula is very simple. We put a graph, the report is on a graph. Like from the surface, if you get high reflection, then you will make it a very big peak. And if you get a low reflection, then you will get a small peak. Like with this picture, oh, there is no peak, so there is no reflection here. So possibly this is an anechoic area. And you can see a big peak here. So there is a big reflected, highly dense structure there. So that doesn't give a good result or make us a little bit confused about what is going on there. So this A mode or amplitude mode is not actually used nowadays, but it may be used in ophthalmology. If you are an ophthalmologist, tell us whether you use it or not, because we found that our book says that their use of A mode in ophthalmology. So it is used to fix the contact lens and to detect the foreign body in the vitreous, foreign particle in the vitreous body. But I think they use B mode ultrasound right now. Okay, so now come to the B mode, B for the brightness. So here we use the brightness term. So what we do actually, we put the sound into the patient's body, we get the reflected echoes, and these reflected echoes are converted into bright dots. So the more the reflection, the more brighter the dots are. So the whole picture actually looks like this, dot, 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 dot substances. This is a still picture. So this is the typical picture of the liver still picture. This is the B mode image. Okay, so if you magnify the image, you can see there are so many dots here representing each and every part of the lever from where the sound got reflected. Okay, so brighter the dot, brighter the more the reflection from that part. Okay, but B mode is a still image. When you are seeing a picture that is moving, that means the real-time image, we call it real-time imaging. So moving B mode, that means the B mode with motion is called the real-time imaging. So we are actually using the B mode and real-time mode spontaneously. So these are quite similar terms in our daily use. Now come to the M mode or motion mode. We frequently use this mode also. So here we just convert a real-time B mode image into a graphical image. So all the layers are converted into a graph to detect any motion. So we use it for, commonly use it for the echocardiography, where you measure all your parameters, and also to see the fetal heart or heartbeat assessment, we use it in obstetric ultrasound. There is something shouting going on around my home. Anyway, some fights are going on. So we also use it for the lung ultrasound. There are so many signs in lung ultrasound where used in the M mode to describe. There is an abdominal ultrasound use. I think I commonly use it for the vessel measurement. We use it for the inferior vena cava, portal vein, or any other vessel measurement. We can use that thing. Okay, so tell me, for which purpose in abdominal ultrasound you use the M mode ultrasound? So this is the picture of the cardiac ultrasound where we are using M mode ultrasound. We just changed the whole picture into a graphical image at this line level. So here we have put this line to the fetal moving heart, and you can see all the layers are converted into a graph. And at the level of fetal heart, as there is a motion, so you can see there is a movement of fetal heart or cardiac valves. And from this motion or movement or image, we can detect the fetal heart rate. So now come to the color Doppler ultrasound. This part will be a little bit long. So my target is to give you an idea about the advanced ones. I know that for the practical use, you will need the color Doppler and 3D modes quite a lot. So I have made long slides for this color Doppler and 3D portion. So be patient and sorry for disturbing. So color Doppler ultrasound is a very popular ultrasound technique nowadays to see the circulatory system. So we use it a lot in our daily life, and this is one of the most advanced and emerging fields in medical science. So be careful, and if you are not planning to develop yourself in on color Doppler ultrasound, you should think it twice. So we commonly use it for assessing the central and peripheral vascular system. There are so many non-medical use, obviously. And nowadays, attached to the 3D or with the 3D ultrasound, color Doppler is used in obstetrics, gynecology, infertility, and all over the body, actually. So we have to know color Doppler quite well. Now, the main advantages are the inexpensive and non-invasive one. So if you want to see the blood vessels of a patient, you have to go with the CT angiogram, cath angiogram, MR angiogram, or anything. But these are expensive and these are invasive procedures, and you cannot repeat those procedures every day. So color Doppler is quite safe and non-invasive, and in comparison to other imaging modality, it's quite inexpensive. So you can repeat it whenever you need. So that is the real benefit of Doppler. And you are assessing the patient on real time. You can do it on bedside. So in case of fetal-maternal, we can early predict the fetal condition or maternal abnormality using this Doppler, because all the changes we see actually first happens for the blood vessels. Then it changes day by day up to the placenta, fetus, and so many things. Now, when you are looking at the mass, you know, each and every malignancy has its own vascular nature, vascular pattern. There is neovascularization going on, everything like that. So using Doppler, you can detect the mass as a benign or malignant, or you can see the or assess the prognosis, recurrence, so many things. So that's why color Doppler ultrasound is now a very important part of our life. For color Doppler physics, we won't go very deep, but we have to know the Doppler shift. You know, when you are putting sound to a non-mobile structure, like you are doing a B-mode or real-time ultrasound, you're putting sound over your body. The sound goes into your body and gets reflected. So what frequency are we transmitting? Like this is my transducer. It can produce, I think, 3.5 to 5 megahertz. I think that we are producing 5 megahertz transducer, a 5 megahertz sound. So we're putting 5 megahertz into my body, and the reflected frequency will be 5 megahertz, obviously. So there is no change of frequency when the structure is non-moving. But when we are putting sound into a moving structure, like if you think about the blood, we think about the RBC. So we are putting sound into the blood vessel, and it is getting reflected from the moving RBC. The frequency that we have transmitted is not similar to what we have received. There is a change of frequency. Now, this is called the Doppler shift, the change of frequency from a moving structure. So we see that when that structure is moving towards the transducer, the frequency change is positive or higher than the transmitted frequency. Like you are transmitting 3.5 megahertz, you are getting 3.500 something. So you are getting an increased frequency. This is called the positive effect or positive Doppler shift. When you are putting sound or getting reflected sound from a structure which is going away from the transducer, the frequency you see getting is lower than what you have transmitted. Like you are putting 3.5 megahertz transducer and you are getting 3.99 something. So this change is called the negative effect or negative Doppler shift. So this is the main principle of Doppler ultrasound. So looking at the frequency change, we can understand where the structure is going. It is coming to the transducer or going out from the transducer. So we can see the direction where we can understand the direction. So this difference is called the Doppler shift, the change of frequency, the transmitted and reflected frequency change. This is the Doppler shift. So color Doppler machines are based on this Doppler shift mechanism. And we have already heard about the positive and negative frequency shift. And if there is no change of frequency, there will be no Doppler shift. So usually our machines show red color on Doppler when there is a positive Doppler shift. And if there is a negative Doppler shift, they show the blue color. So red and blue doesn't mean artery or vein. It means the direction of blood flow. So we'll talk about that a little bit later. So this Doppler shift actually depends on or based on this equation known as Doppler equation. You see F equal to 2FB cos theta by C. There's a complex of actual equation, but you have to understand that why we need this equation. That's all. I won't go very deep. So our machine knows the Doppler shift. They know what is the transmitted or transducer frequency, like 3.5, 3.6, something like that. When the sounds get reflected back to the transducer knows that this frequency is getting reflected, like 3.5, 3.6, whatever. So we actually know the Doppler shift. We know that when our mathematicians can't or physicians can physicists can make a calculation easy, they try to put some 1, 2, 3, 4 or some constants. So they have already put constant here, and they have put a 2 here to adjust the equation. This 2 actually, because the sound is going to the patient's body and coming back, so 2 events are happening. So there is a 2 here. We know the transducer frequency. There is a blood velocity, that is the V. Okay, we'll talk about that. There is a cos theta, that means there is an angle issue here. Now, that will be divided by the propagation speed of the medium. We know the propagation speed, like the velocity of sound in the soft tissue is actually 1540 meter per second. So our machine knows that. So actually, our machine knows all of this except blood velocity. So putting all the values here, through this calculation, our machine will detect the velocity of the blood vessel. So this is the principle of this equation. We can detect the blood velocity or velocity of that structure. So there is a cos theta. We know that if the theta is 0, the cos has the highest value. And if it is 90, the cos will be 0. So when you are putting the sound, if the blood vessel is parallel to your sound beam or making a 0-degree angle, whatever, so the result will be the best. And if you are putting sound at a 90-degree angle to the blood vessel, there will be cos 90-degree, that means a 0. So the Doppler shift will be 0. So there will be no flow showing on Doppler. So whenever you are putting Doppler, you should be very careful about this equation and this cos theta. Like, let me show you a lever. You see there is a lever and you can see the hepatic veins here. This is the middle hepatic vein. This is the right hepatic vein. The middle hepatic vein is showing very good flow, but the right hepatic vein is not showing very good flow. So there will be Budd-Chiari syndrome, there will be thrombosis, whatever, but it is quite completely normal. So why this vessel is not showing any flow? Because it is perpendicular to our sound beam. So we're putting the sound like this, and it is perpendicular to this sound beam. So there is a 90-degree angle over here. That's why we are not seeing any flow here. So when we are putting transducer to and trying to see blood vessels, you should be a little bit careful about that. Otherwise, you will make it a misdiagnosis as Budd-Chiari syndrome, whatever. So just change the direction. You see the vessel from right costal margin or something like that. You'll see very good amount of flow. in this vessel. So be careful about that. Like here, you can see different colors, but at the central part, you may see there is a color void area or less flow, because it is the area where the sound beam is creating a 90-degree angle. So at the center part, there is maybe a gap of flow. Okay, so you see the red and blue color. So red means towards the transducer flow. That means the flow is coming to the transducer. Blue means the flow is going away from the transducer or away from the transducer flow. So this is the positive and negative effect. Positive means red, negative means blue. So it has no relation with the artery or vein. Here you can see this is a single vessel which is showing red and blue color. What does it mean? It means that this flow is coming towards the transducer and this flow is going away from the transducer. So this is the central point of the transducer. So we are putting sound beam from that part. So we can understand that this flow is coming to the transducer and this flow is going outside the transducer. So ultimately, we know the blood vessel is flowing to this direction. So this is the benefit of color Doppler. You can understand the direction of the blood. So here we also can change the direction by our manual setting. So to understand the direction, you see there is a scale over here. So upper part is indicating that towards the transducer flow and the lower part indicating the air from the transducer flow. So in my setting, the towards the transducer flow will show red color. But here I have inverted it with the invert option. Now my machine is showing that towards the transducer flow is blue and air from the transducer color is red. So you can change it depending on what you need. So now the blue means towards the transducer, red means air from the transducer. So these are sometimes make you confused. So be careful. Towards the transducer means this part. So just change it whatever you need. So here is also some mixing of colors. So this flow is coming to the transducer and this flow is going out from the transducer level. So the flow direction is from screen's left side to the right side. Okay, so here you can see there is an inferior vena cava and other hepatic vessels here. So this is the towards the transducer flow as red. Now I have changed it towards the transducer flow to blue. So you can change it whatever you need. So if you are in the spectrum, then you will see that the waves will get to the opposite direction depending on the scale you have changed. So be careful about these scales. Okay, similarly, here you can see this is the red color, this is the blue color. We have inverted it to red from blue. So the waves are also getting opposite. So when we are talking about the color flow imaging, you have to understand that there is not only two colors. We are not using only red and blue. We have many other colors. So if you look at this scale, you can see from dark blue to light blue, even sometimes it may get a greenish like pattern, from dark red to yellowish pattern. So this outer part indicates the high velocity flow. So always remember that our color Doppler machine will show you high velocity flow as a light color. So you are seeing here, you can see the red color, dark red, it means low velocity flow here. Here you can see the lightish color, so it indicates there is a high velocity flow going on there. Let me just check a small thing. Okay, so we can't say how much velocity flow is going on here, but with the help of this color flow imaging, we can understand that the flow has a different velocity going on in this image. So usually one single vessel has different parts showing different velocities. Usually the central velocity is the highest one, and the peripheral part around the vessel wall has a lower velocities. So we have the continuous and pulse wave Dopplers. In case of continuous and pulse wave Dopplers, we have different principles of piezoelectric crystals working. It's quite complicated, but if you want to make it simpler, let me help you. So in case of continuous wave Doppler, we have two different sets of crystals working. And in case of pulse wave Doppler, a single set of crystal is working. So when there is two sets of crystal working, you can take like continuous wave Doppler, we can take a large load. Just a little bit change of my velocity net speed. Okay, just let me check. Okay, so as two people are working here, so they can detect high velocity flows with continuous wave Doppler. But as on pulse wave Doppler, a single person is working, so the workload is very hard for this person. So they can't actually detect high velocity flow. So if you need high velocity flow detection, you will use the continuous wave Doppler. Like for aortic stenosis, there will be a very rapid jet of flow at the aortic valve. We'll use continuous wave Doppler to detect that. But for pulse wave Doppler, it won't be very helpful. Now, what about the pulse wave Doppler? Pulse wave Doppler, in case of pulse wave Doppler, as a single person is working here, so sound beam is transmitting from a piezoelectric crystal and getting reflected back to that crystal. So this crystal knows what can be happened in between. So that's why with the single crystal, you can get a better information. So more depth of information can be gathered. So to say it easily, if you use pulse wave Doppler, you can understand what is going to happen in the systolic phase, on the diastolic phase, on in between, everything. So whenever you need a big information, you will use the pulse wave Doppler. Whenever you need to know the high velocity flow only, or you need to know the velocity only, you can go for the continuous wave Doppler. This is the basic use related talk, but there is so many deep talks here. So let me show the pictures. This is the continuous wave Doppler. We commonly use it for the echocardiography because we need a high velocity flow detection. But for the peripheral arterial Doppler study, we need more information. So for that reason, we need to know the systole, diastole in between them. So you use the pulse wave Doppler for the peripheral and all the abdominal and obstetric Doppler ultrasounds. So we have different terminologies like duplex, triplex. You make confusion with these terminologies. So what is the duplex imaging or duplex Doppler? Duplex means two things going on. The first thing is the real-time 2D or B-mode ultrasound. The second one is the spectral Doppler. There is no color here. So if you look at this picture, we have a B-mode or real-time mode image, and we have put spectral Doppler. We'll talk about the spectrum later. So we have took the spectrum and pulse wave Doppler, and you can see there is a spectrum here. So two things happening here. So we call it duplex Doppler. But nowadays we are not doing duplex. We are actually doing triplex. So duplex is a misnomer right now. We are doing the triplex imaging or triplex Doppler. So we are using three different modes here. So first we put a real-time imaging. We check the structure. Then we put color Doppler over there. So there is a color display, red and blue colors. And then we put the spectrum, pulse wave Doppler. So three things that are happening here: real-time, color, and spectrum. This is the triplex Doppler. So main difference is the color. So when you are using color imaging here, this is the triplex imaging. So all of us are using triplex Doppler, but we, as a misnomer, we still use the duplex term. So this is the grayscale image or B-mode image. Then we put the color flow imaging here, red or blue color, but we can't see any velocity, or we can detect the actual quantitative assessment. We are doing some qualitative assessment here. So for quantitative assessment, we put the spectrum here. From this spectrum, we will assess the measurements. So three things are happening. So this is the triplex Doppler. We have power Doppler, where we try to detect the motion or slow flow or perfusion. So this is the power Doppler, where we don't use that complex Doppler shift equation. So it's not angle dependent. It's it depends on the RBC flow. So there is a signal from the moving RBC. We'll put it with color. So this is very good for assessing the perfusion, like when you need to understand the perfusion in case of ovarian torsion, testicular torsion, or you need to assess the renal peripheral flow, you'll use power Doppler. Uh, it is not dependent on the angles and so complex things. So it gives you a good resolution and good picture. But the problem is that with power Doppler, you can't assess the direction of flow because it's a single color image. And you can't assess the speed from this picture. Like we saw that the color will get lighter for high velocity flow, but here this mechanism usually doesn't work. So with this image, you can't say this area is having high flow or low flow. So that's why we can't understand the speed. So, so we use power Doppler to only detect or to assess the perfusion. Like for kidney, you can see I have put color power Doppler, and you can see the vascularity up to the distal part, the highest distal part of the renal system. So this is the beauty of power Doppler. You can see this is the kidney, and it is showing perfusion up to the last part of the cortex. You can also use it for different organs, like there is a lymph node enlargement going on here. So we put color Doppler, and it is showing a pseudo kidney appearance with a high vascularity inside. I commonly use power Doppler for our penile artery assessment. In case of flaccid penile arteries, cavernous arteries, it's very difficult to detect the flow within those arteries with color Doppler. So at the time, I commonly use power Doppler to see the vascularity or see the flow within this cavernous arteries and take the sample. You can say that, yeah, you are using this and you are checking the velocity with power Doppler. No, we are not checking velocity with power Doppler. We're checking velocity with pulse wave Doppler. Okay, so with looking at the flow, we can't say the velocity is high or low. That is the principle of no speed detection with the power Doppler. Forget it. So come to the spectral Doppler. So we have put these spectrums. There are some graphs, and we commonly have three different types of graphs, like triphasic, biphasic, and monophasic. When you are seeing three phases, systolic, reverse diastolic or reverse part, and positive diastolic flow, so three parts. So this is called the triphasic, which is very common in high resistant waves. So high resistant vessels like peripheral arteries have this type of wave patterns. So biphasic means two phases. It may be from the baseline to same direction or different direction. There will be two phases. Like here, we have put a positive systolic component and a positive diastolic component. It may be a reversed component also. So two phases. So this is biphasic, which is very commonly seen in the central type of or low resistant vessels. In case of monophasic, there will be a single flow, and you can't detect the systole or diastole quite well here. And this is commonly seen in the peripheral veins. So here we have shown you a triphasic wave pattern of the anteriotibial artery. You can see a positive wave. This is the baseline on orange color. So this is the positive wave, this is the reverse wave, and this is the positive diastolic wave. You can see this is the biphasic wave pattern where there is a systolic positive wave and there is another systolic diastolic positive wave in the internal carotid artery, which is called the biphasic wave pattern. Here is a monophasic wave pattern of which we have taken from the saphenofemoral junction, and you can see these venous waves. It gets changed with time due to the respiration, which is called the respirophasic pattern. So these three are the waves, but unfortunately, here is another picture. We also can see triphasic wave pattern in the veins also. The veins nearby to the heart showing the right atrial pressure may demonstrate this type of triphasic pattern also. So these are the three patterns we try to describe, triphasic, biphasic, and monophasic. But unfortunately, these terminologies make us confused. Like when I'm showing you the internal carotid artery picture, I'm telling you that this is a biphasic wave. But similar wave in the lower limb, I will show you, I will tell you as monophasic wave pattern. So that is the confusing state. Those two waves are quite similar, but you are telling me that this is a biphasic and this is monophasic. So these terminologies are creating worldwide confusion. Triphasic is okay, but biphasic, monophasic sometimes makes confusion. So that's why there is a consensus guideline from 2020 where 50 persons from the Society of Vascular Medicine and Society of Vascular Ultrasound have concluded these terminologies into two terms. First one is the multiphasic. So nowadays we use the term multiphasic to describe both triphasic and biphasic. So if you see a wave in both direction from the baseline, so you see there is a positive, there is a negative or something like that. So if you see wave with a forward and reverse component, then you will call it a multiphasic wave pattern. So no matter it is a biphasic or triphasic, if the wave is present in both sides of the baseline, you'll call it multiphasic. So in case of monophasic, the direction is that you'll see the wave in a single direction from the baseline. So it will be on the upper part, or positive part, or the negative part, whatever, but you will see on a single part and it will not cross the baseline. So this is the monophasic wave pattern. Now, if you follow this guideline, you will see there are so many descriptions about describing each and every multiphasic and monophasic waves. So don't forget to check. This is a free I think free journal. You will just can search the interpretation of peripheral arteries and venous Doppler waveforms. You will see this PDF available on the Google. Okay, so check that we are not using triphasic multiphasic since 2020. So it's 2024. Still we are using. Very bad. So we have other different advanced options like B-flow imaging. I don't know what is B-flow option in other machines. In my G machine, it is known as BF option. BF is not for the boyfriend. This is B-flow imaging. So B-flow is based on grayscale. So it will show you an angiogram-like picture, and it will show you the flow of the blood vessel, and it is very good technique to detect the flow within the carotid or peripheral arterial system. So it's not angle dependent, and it not gives you a good resolution picture, but is very helpful to detect the stenosis. Like for carotid arterial system scan, I feel confused about the carotid bulb. Sometimes my machine can't show a good amount of color at the bulb region. So at the time I use this B-flow option to assess the actual flow from the bulb and whether there is any narrowing out here. So here you can see there is a plaque over here, and this soft plaque is causing narrowing, but I'm confused, so or I want to be a little more sure. So I used B-flow imaging, and you can see there is no flow here. So this may help you to confirm the lesion. Here you can see the flow is getting disrupted over here because there is a plaque out here, which is causing the focal narrowing. So B-flow is widely used, and here you can see a flow coming from the fetal nose. So you are doing biophysical profile where you check the fetal respiratory movement. So you are putting this B-flow over the fetal nose, and you can see the flow here due to the respiratory movement of the fetus. So you can use it in different purpose. So we have the microflow imaging, which is also known as super microvascular imaging, depending on which manufacturer's machine you are using. So it is based on power Doppler, but it is more sophisticated or more sensitive to the movement. That's why if you are trying to see more precise vessels like the fetal head vessels or renal vessels or something very sophisticated thing, you can use this microflow imaging. In my practice, I commonly use this option to detect the ovarian torsion. Ovarian torsion is quite difficult for me, so I use this one to confirm. Here you can see the kidney. I put the Doppler here, and this is the slow flow HD option in G machine. You'll get it the power Doppler option Yeah, you will get it on the power Doppler option. So I'm using this slow flow HD or microvascular imaging to assess the renal vasculature here. So you can also use it to the cranial ultrasound and even to see the fetal vasculature. You can see these tiny vessels. Do you know the name of this vessel? Tell me in the comment section below. Okay, so this vessel gets obsolete or absorbed or reformed after birth. Otherwise, it will cause intraocular bleeding. Okay, so we use the 3D ultrasound in association with the Doppler to give you a realistic angiogram-like picture also. Like in this testis, you can see the very good vascularity using the Doppler and 3D. So this is the fetal heart. You can see very good pumping of the fetal heart, and you can see the hepatic veins also. So these realistic pictures are still in the primary generation level right now. So it's if you want a very good pictures in, so definitely you have to practice a lot. Otherwise, it will be difficult. So here we have made multi-sectional imaging. I'll talk it about a little bit later. And you can see the vessels of the testes quite well. Even this acute orchitis patient, this was an acute epididymal orchitis patient. You can see a very good vascularity with 3D and Doppler. You can see these realistic, quite good pictures. And this is the new generation pictures, you can say. So we are putting Doppler and we're taking multiple sections, and you can see this lymph node of a critical patient. I think from the lymphangitis or lymphoma, I have forgotten. So this patient is having the hilar arterial flow from here, and it can be demonstrated here on 3D with Doppler. So we use it also for the cardiac scan, fetal cardiac scan or echocardiography, and you can see very good flow here. If you look carefully, the four-chamber view looks quite normal here, but if you look here, there is a ventricular septal defect through which the flow is coming. So this type of sophisticated diagnosis could be made with using 3D associated with Doppler. So we are taking the picture and reconstructing it to real heart-like pictures nowadays. We can also use it for the renal vasculature assessment, and you can see I have put Doppler, power Doppler, as well as 3D to make this picture, which can't actually demonstrate us anything. But we reconstructed it, and now the picture looks like this. And after more reconstruction, we can see the renal vasculature like this tree-like appearance. So this is the newer innovations going all over the world. So if you practice a lot, then when these options will get easier in near future, you'll be the boss. Okay, so let's go for the 3D ultrasound. I'm sorry because I'm taking a lot of time, but as the records will be preserved, I hope it will be helpful for you. Okay, if it is helpful, then I will be very thankful. Let me just check the comments if any questions there. Feel free to ask any question obviously in the live video, because I have posted it in different groups, and I obviously can't see the comments there. Okay, there is a fantastic question about the Doppler. I will just try to solve that at the end of the session. So be patient. Let's go for the 3D ultrasound. I know, like me, many of you are interested to know the 3D ultrasound and you love to practice. But the main problem about 3D ultrasound, I think I have seen in my country, is the transducer is not available. So if you don't have the transducer, that will be a difficult thing to do the 3D ultrasound. Fortunately, some manufacturers like Philips and Siemens, thanks for that. They're not sponsoring the video, but they have some transducers using the curvilinear transducer. You can make 3D reconstructed images. I have used Philips and Siemens machines in my past practice, where I use my curvilinear transducer, manually swipe the transducer, and try to take 3D pictures there. So, but not the 4D one. So all the manufacturers should do that also. Anyway, so that will reduce the cost. So 3D and 4D ultrasound is the transducers used for the capturing of volumetric image. So this is a still image for the 3D. And if you can see these 3D images moving on real time, it will be called 4D ultrasound. So we'll talk about the 4D later. It's an expensive one. The transducers are very expensive. I know about my transducer. So it's very expensive. And 3D and 4D needs patience. So you won't be able to learn it in a day. So you need patience. It's a slow learning curve. Nowadays, we are using 3D and 4D for all the scans of obstetric, cardiac, abdominal, vascular, and whatever you say. And a lot of innovations are coming in next futures, because we see the ultrasound manufacturers are working very hard to make 3D ultrasound more easy. And also they're trying to implement many different AI functions with 3D ultrasound. So if you want to apply 3D, apply AI function in an ultrasound machine, 3D is the best option to use that. So make sure 3D will get more options in near future. So 3D, 4D has ultrasound has three different functions, three different mechanisms. So we do the volume acquisition, image reconstruction, then we put the image on the display. So for the volume acquisition purpose, the curvilinear disc transducer on my hand can transmit the sound in a single direction, in a single plane. So I'm putting it on this part. So it is putting the sound like this. So I'm rotating the transducers to the transverse section. So it is making a transversely put the sound. So now, what about the 3D transducer? So they make a volumetric sound like this prismatic sound. So they put the sound in different direction like sagittal, coronal, axial, and take the data from a whole large area. This mechanism is called the volume acquisition. So we are transmitting the sound on sagittal, coronal, axial plane and getting a large information from the whole area, a 3D information. So now this 3D information will be reconstructed and attached each other to make a 3D image. So this is the image reconstruction. Like here, I have a tiny embryo. We have put colored 3D ultrasound. So we acquired all the data and displayed it as for the image reconstruction. So this is the reconstructed image, but this is the raw data, so it doesn't look quite good always. You need to adjust it a lot. So we need to adjust it through many different functions. It needs a separate lecture, I think. So usually in a very short talk, when you are seeing the first image, you see these green dots, you always should put it quite well. And the below area or the beneath this green line will be shown on the 3D image. So if there is any hand here, you will see the hand, like here you can see the hand. If you see any placenta here, it will come in front of the baby's face. So you have to adjust this picture quite well. And after this sagittal section, you have to adjust the axial section, then you have to go for the coronal. So all these adjustments will give you the good picture. It's not that difficult. You can do it in a different way. So here we have put the section of the fetal cardiac four-chamber view. There is a pointer which we have put in at the central part through the cursor. Then we adjusted this line and we want to see the central of the heart. And after this adjustment, now you can see this four-chamber view over here. Just let me check a little. Okay. So here we couldn't make a good picture on the grayscale. So we took a raw data, then we adjusted these lines, and now we can get a good picture. So all this happening because of these adjustments. Like if you see this green line over here at the front part, now you can see the fetal phase, but if you put this green line, you can change its direction. So now you're putting it on the back side, the image will get disrupted. Like now you are seeing the fetal face from the inside to outside of the baby. So the picture looks this like. So the reconstruction process is very important. We'll talk a little about this also. But before that, we want to go for the image display. So we usually try to display the image in multiplanar reformatting or volume render technique. So actually the picture looks like this boxy appearance, but we remove the margins and the picture looks like this realistic one. So let me show you the raw data. Here I have taken a picture, just put the prop, put the transducer, put the 3D option, and just collected the data. This is the data. So you can see the face over here. Okay, this is the fetal face, this is the eye, this is the nose, but I'm not satisfied with this picture. So after reconstruction, you can see this is the picture. Now, this is the whole process you have to go for getting this picture. But always remember that never get satisfied with what you get. So you always have to go further. So I'm not satisfied with this facial image. So I have tried to edit a little more, and now the picture comes like this. So you have to be patient and you have to work very hard. You have to know your machine to get a good picture. Okay, so there are some adjustments also, like if you think about a picture on your mobile phone, you edit it a lot, like your face doesn't look like you. So what we see in Instagram or Facebook. So you have to edit like that. So there are so many options, like a smoothing option with which you can smooth or make some rough skin or texture like skin. So whatever you like, you can just change with the smoothing or texture option. There are light source option, or which you can change the direction of light source, which will give you a cinematic vibe. Usually with this type of sepia image, you can't change that, but you can change it on this pink-like or HD or high definition 3D images. So here you can see there are 6 pictures, but I have changed the light direction. So each and everyone has a new look. So with a single image, you can now make 6 different images just with changing the light source. So which one is very good? I think I will go for this one or this one. This is quite like a horror movie. So it is very important to change the light source because it may give you different vibes and it may give you different images. So we can use the threshold option. I frequently use this option to change the density of the picture. So this is an increased threshold, so you can't see the fetal face quite well. So decrease a little and you can see the picture quite good. You can also change the chroma or color. You can also do it for the grayscale ultrasound also. There is a chroma setting. You can change the color from grayscale to sepia to anyone you want. So just change it whatever you like. Ask the patient, you like a blue baby or you like a pink baby? Whatever they say, do it like them. Okay, so the scalpel option is the commonest option I think I use after threshold. So you have to edit a lot. Like here, I couldn't make a picture without the placenta over the fetal face, so I need to delete it. So rotate the image using the XYZ axis options. These options are available in the keyboard. I will show you the keyboard also. So after rotating a little, then I will edit it, putting the scalpel or scalp option or cut option or edit option, whatever in your machine. So cut this part and now the face will look like this. It looks quite good, but I have said you that you shouldn't be satisfied with this image. So I need to cut this part also. So I will rotate the image and cut it again. Now the face looks quite good, but never get satisfied. So now I have rotated here and cut this part, and now the picture looks like this. So these are beautiful pictures, like the Egyptian mummy, I think. So you can edit a lot if you save your 3D data in your machine. So in your free time, try to practice a lot with this 3D data. Okay, so here you can see the placenta is over the fetal face, so the picture like comes like this. You can also adjust this green line so that you can get this type of picture. Otherwise, you can just cut it like previously I said. Let me show you a case. Here, I couldn't take a good picture, so the raw data came like this. I can't understand where is the head. Okay, so I edited a little, then the picture comes like this. What I said, you shouldn't get satisfied. So I edited a little, now the picture comes like this. So I couldn't make a good view of this area. It was distracted. So I decrease the light here and I put the light source from this part. So it gives a cinematic picture. Now, you can display the 3D images in different pattern. Like here, you can see this is the high definition 3D. In Philips machine, this is known as TrueView. In G machines, they are call it HD Live option, I think. So this is the surface typical 3D options available in chip quality machines. And still we use this option because this is the common shape we are accustomed to. So anyway, this is the surface. You can see the gallstone here. I have forgotten. This is the gallstone. And now this is the glass view. You may like or not. This is the glass view showing this stone. We have the skeleton mode. It may be shown as a skeleton, skeletal, X-ray, or bone mode. So here we can see the fetal skeleton, and you can detect skeletal abnormality, especially spine abnormality with this skeleton mode. It can also be used to detect the calculus within the gallbladder or any other part. So the main principle is that the very highly echogenic areas are shown only in the image, rest are getting deleted. So that is the principle. So bones are very bright, so we are trying to see the bones. So the opposite one is the inverted option. In inverted option, we try to see the bright structures as dark and dark structures as bright. So the blood vessels are the dark structures. Here you will see the blood vessels as bright structures. Like here, I have put inverted option on a liver, and you can see this is the hepatic vessel. So if you have a patient with bile duct dilatation, you can put this option and you can see the bile duct dilatation quite well. So you can use it also for any other options that comes in your mind, like this is the ventricle. So I have put invert option and you can see the ventricles quite good here. Here is the endometrium, where you can see the hypoechoic nature because we have an invert option going on. So this is the echogenic endometrium, which appear to be dark here. So if there is any gestational sac or retained products, you can easily understand from this image. Also, some Mullerian duct anomalies can be detected from this image also. About the 4D ultrasound, the 4D is nothing but the real-time mode of the 3D. So there will be motion added here. So moving 3D is called the 4D ultrasound, which we commonly use in case of pregnancy. So here you can see the fetus is moving on the grayscale images, and we have reconstructed it to a 3D image where you can see the fetus is also moving here. So the machine have 3D and 4D options. Here's the 3D option, which is dark here. And we have many settings on the screen, like transparency to make it transparent or make it more visible. So smoothing slice option to cut the image into different slices and to check from outer to inner side, you can just cut the areas. So this is one type of sculpture or cutting service. So there is a threshold option to increase the density or decrease. So just like mobile editing, you need nothing to know about the mobile editing, you just change it. So similarly here, you don't need to understand what should be the threshold level for 39 weeks gestation. There is no need to know that. So you just change it like freestyle and you'll get a good picture. So there are some screen options like 4 screens, 1 screen, how you want to show that screen, which screen you want to show. you can also choose from there. So there is the option to change from glass, surface, or HD option, and cutting option is here. You can rotate using XYZ options. So in G machine, this G machine shows these options also. So you can see these are the 3D and 4D options. We have the freeze options. I'll talk about all the buttons a little bit later. Just for the 3D ones, you can adjust all these settings from these buttons. Using these buttons, you can change those. Okay, so let me show you an example. I don't know whether it will get slower. So here is a 3D picture I have taken, and the image doesn't look quite good. So I will just try to edit it a little. So you can see that I'm rotating the image, and I'm just trying to think about the area I want to cut first. Don't say the patient that I'm cutting your baby's hand now, I'm cutting your baby's face now. That's the weird thing. So using the scalp option, I'm just cutting the adjacent areas. So now after rotating, I'm just cutting and cutting again and again. So now the image comes like this. So I will change the threshold also a little bit. I'll rotate and edit a little. So I'm magnifying the image, changing the threshold to get a good view. So this looks quite better, and I'm changing the light source to give a good cinematic vibe here. So this looks quite good, changing the threshold a little bit. Now, after changing the light source and making it a larger one, now you can see a good picture. But here is another notorious area, which I have also deleted. So deleting again and again, and now you are getting a better picture. So I changed it to the surface view, which doesn't looks quite good. So better to stay on the SD Live option. Let me show you a tiny embryo. So this is the early pregnancy embryo, and you can see this is the grayscale image. So why would we love to go for the 3D? So we have changed it a little. We are adjusting these boxes, and if you don't want to adjust, just go for this image and you can edit it all here. So I'm just putting everything on the position. So just editing. Look at the image. So I'm using these 4 options to change. So I'm changing the slice, getting a deeper view, but other options should be changed also. So I'm changing the threshold also. I think I should change the mode to see the good view. Okay, so this is the embryo. You can see the yolk sac here. I'm just rotating the image to get a good view. So just cutting all the areas to see only the area. Okay, so I'm changing the modes from one to another. This is the depth rendering view to see the depth or get a view of the depth. So this is the skeletal mode, will show nothing. Invert view will also show something. So better to go for the HD Live or true view option for the Philips machine. So now you can see a good view of the embryo. This is the glass view. It may not good. Okay, this is not the penile part. This is the umbilical cord actually. So sometimes you may make confusion. So this is the embryo, tiny embryo within the gestational sac. We can change the light source to give us very good cinematic vibe here. Okay, so this is the end image. So here you can see another fetus. It looks quite not good. So there is a low threshold here. So we want to increase the threshold. So here I'm changing the threshold, just increase the threshold a little. I'm changing smoothing, transparency, every options. Now you can see a realistic picture here. So I'm changing the gain also, B gain also. So now you can see a very good picture. So I'm changing the light source. It's giving a very good vibe. You can also change the settings to get the high definition view, and you can see the baby looks now very good. Isn't it a very beautiful picture? So you can magnify a little also to get another view. So here I am showing you another picture taken by my senior colleague. So I just, in my laser time, I changed the image. So patient didn't get this image. So I'm just editing very rapidly. Oops. So magnifying the image, just to see how I'm changing. So all the options, I'm not actually doing it intentionally, rather I'm doing it in a freestyle mode. So just changing it and trying to see how it looks. So it takes time, it takes time. So that's why uh, you need to be a little more patient, and patients also need to be patient to get the report a little later. Otherwise they will miss this type of images. Okay, so 3D is used in obstetrics quite a lot. We can check with the bony setting, the bony lesions. Even you can change with the multi-planar setting, this type of view to assess the fetal bony structures. We have the tomographic ultrasound imaging mode, TUI, with which we can just take the image like a CT scan, or we take this area view, and then we choose the area we want to see in different sections. Like here, you can see the axial sections of the whole fetal parts. We can choose the millimeter of thickness, what we want to see, how many images we want to see, all you can set. So here we want to see the fetus from left to right in a sagittal section. We have chosen this part and you can see these images. Here we have chosen from anterior to posterior and you can see the coronal sections of the fetus. So these are getting easier day by day. Here we have chosen from the heart, from superior to inferior part, and you can see all the axial sections here on single image. So we have these options like rendering, or we have the multi-planar options. We have the Omni view with which we can change. We will talk about that. And we have the volume computer aided diagnosis, that is the VCAD option, which we commonly use for the cardiac scan. So here we have just put the Doppler, we have choose the area, and now you can see all the parts are shown in axial sections, and you can see the ventricular septal defect here just with a single scan. So AI is being used for detecting the lesions and detecting the measurements here nowadays. So we have the intracranial measurements, we have the cardiac measurements already implemented in our ultrasound machines, but soon it will be implemented in all other parts. So here you can see we have changed the image from grayscale to 3-dimensional, or you may say 4-dimensional, moving fetal heart. So now I'm going to show you a tiny example. We have just the VCAD option. First, we have got an instruction to put the heart like this. So we are rotating the image and trying to adjust the depth so that we can put it like this. So now you will just click on the AI option, like a Sono VCAD on my machine. So I have confirmed the alignment. Now the machine will automatically adjust all the pictures. You'll choose the 4-chamber, ductal arch, aortic arch, whatever view you want, and the machine will show you the rest of the results. So it's a fantastic way. So it's still in the primary stage, but it will get developed in near future with all the measurements, all the markings. Already some manufacturers have implemented these options. So these are the fields where you can work in next futures. So ultimately, we can get this type of results, and the heart may look like this. We are working a lot to develop the 3D ultrasound in my country. I hope similar things are going on in your country also. So we are using this multiplanar shots to also check the embryo and to assess the cardiac dysfunction or cardiac abnormality in a very early stage. So these are very primary assessments. Still, we are working with that. And remember that in next 10 years, early age or early first trimester fetal echocardiography will be a popular technique. So using Doppler is extremely safe for the early pregnancy ultrasound. Make sure we are using X-ray as a safe technique for the pregnancy. Already books have told that. So if you think the ultrasound can cause harm to the young baby in the womb, it's totally just unwise decision. So Doppler is extremely safe in pregnancy. We'll talk about that. So here you can see we have put colored Doppler and 3D, and you can see the vascularity of the embryo, and we can assess the early congenital abnormalities, especially the cardiac abnormalities, at least transposition of great vessels and so many other things with our machines, and machine manufacturers are going for that. So we can just show you the fetal heart, embryonic heart, like this appearance right now. So we can also use it for this multiplanar or tomographic imaging to assess the cranial assessment. Our machine can also measure all the structures here with proper marking, but still they are not so much reliable, so better to do manually. So we have taken the section from the kidney level, and you can see all the renal eggshell sections here. We can also use 3D ultrasound for other organs, like here we can see the hepatic cysts on 3D ultrasound. And in case of patients with gross ascites, don't forget to use 3D ultrasound, because it's a very good opportunity to see the abdominal structures on 3D. Here you can see a chronic liver disease patient having a hepatic cyst, I think, and these are the intestinal loops. All can be seen on 3D ultrasound. Here you can see this liver with a 3D ultrasound. And if you look at here, you can put 3D here and you can get the small intestinal view like this. So if you practice this frequently, then when the machines will get easier, you'll be the boss. Like another use, you can see this is a gallbladder, and you can see the gallstone. If I ask you that, what is the shape of this stone? Is it round? Is it oval? Is it irregular? What it is? Now you can't say the shape from this image, because in case of due to posterior-acoustic shadowing, we only can see the surface of the calculus in day mode. But this is the shape of the stone in this patient with 3D ultrasound. So it's a coin-like stone in this patient. So this is 2024. So we should know the shape of the stone with ultrasound by this year. Okay, here you can see the gallbladder with some sludge-like stones. So I want to know the shape of this stone. So here's the shape of these stones. So they are actually with some sludge, looks like this. Here I'm showing another gallbladder filled with calculi, and what will be the shape of these stones? So here's the shape. So they are square-shaped stones within the gallbladder. So we can detect this. So here is a floating stone. I think I have shown these calculi in the acoustic shadowing part. So they're floating because of high cholesterol component. Now, when we put the color 3D ultrasound, you can see this stone's shape. So here's a gallbladder helminth. This is the ascariasis, and it was misdiagnosed as calculi, though it's getting calcified. So here's the picture of the coiled ascariasis, so of this image. Here's a renal cyst. I sometimes gets confused about the parapelvic and peripelvic one. So this cystic area looks like a parapelvic one, but when we put 3D over it, now you can see the cystic area comes from the medullary part, that is the peripelvic cyst. So you can locate the lesion with the 3D ultrasound, because you can change the slice. You have taken the whole volumetric data and you can choose whatever you like. So here is another picture where I'm using the Omni View option. So this patient had a cyst, I think 2 cysts here. So I was confused, sorry for the data anyway. So I'm just changing the multiplanar format. So I'm just moving it from here to here, and just I want to see this area. And now you can see that when I'm changing the part, and the cyst is not two in number, rather it's a single cyst which is quite large. So I'm rotating the area of view, and the thickness can also be changed. And while I'm moving here, you can see there is a septation with a thick part over here, which should get attention, and the patient needs further evaluation also. So you can change. Like here is an acute nephropathy patient with a swollen echogenic kidney with some perirenal collection also. So this is the left kidney of this patient, which is also echogenic. No, I'm not detecting acute nephropathy with 3D or color Doppler. But here we have put color Doppler, power Doppler, and we put 3D also. So the picture came like this. I have shown this picture to you. So here's the raw data. So I have deleted the background, deleted the rest of the vessels I don't want to show, and the picture came like this. Similar thing happened for another kidney. So the raw data came like this. So I rotated the image, I deleted the background, and the picture came like this. Then further edit and change of light source gave this type of view. For the cystitis, it's a very common that I see on the reports. It is written as urinary bladder polyps. Polyps in the urinary bladder is quite uncommon. So if you use 3D ultrasound, you won't get confused. Like here, you can see some polypoid areas. These are the trabeculations. So if you put three-dimensional ultrasound here, you can see this chronic cystitis patient. In this chronic cystitis patient, these are the wall irregularities, or known as trabeculations. So you can see a very good picture of trabeculations due to chronic cystitis in this patient. So what about the catheter? You can see the catheter here. And if you put 3D, you can see this catheter balloon within the urinary bladder. So here is the four-dimensional ultrasound. This is not the penile part. This is the catheter. Okay, so my another favorite part is the prostatomegaly or prostate enlargement, where you can see the intravesical prostatic protrusion, or IPP. So which can be converted into three-dimensional image, and this is the projected area of median lobe, which is protruding into the urinary bladder, causing the problem. So here is a very big prostate, and you can see the enlargement of the median lobe. And with four-dimensional ultrasound, you can see this enlarged part through the urinary bladder lumen. And this is the prostatic urethra. So here's the good vibe pictures. So this is 2024. So clinicians actually expect better pictures from you. So you can just give patients this type of pictures, and there will be no confusion about what is going on inside his body. So about the gynecological ultrasound, we are using it quite a lot, and I'm very fortunate to see many reports using 3D ultrasound for this purpose. So here's a hyperstimulated ovary, which is shown on a 3D image. So you can see multiple follicles here. So if you have the Sono AVC or any other similar like options, you can use the AI of your setting, and the machine will automatically detect all the follicles with their measurements from your raw data. Though it's not very accurate, I think, because you see the data is not actually accurate. They miss so many follicles and they include so many other follicles, but still it has a good future. So they will calculate all the cysts available in the ovary, so you may get a good help. So for adnexal lesions, you also can use it, especially for the dermoid. You can see the dermoid ball here, which can be presented on 3D. I use it to see the molar tooth inside the dermoid. So tooth can be well understandable using 3D. I think I have a video of dermoid cyst showing molar tooth on my YouTube channel. So here's a ovarian mass. So you can use the 3D to demonstrate it. And obviously with multiplanar scanning, you can check the solitary part or papillary projection, whatever you need. So also we can use it to evaluate the endometrium, especially if you mark the endometrium on your 3D setting, then you can see this type of picture. And with this type of picture, you can easily diagnose or exclude the Mullerian duct abnormalities like the biconvate uterus or uterine didelphys having two separate cervical canal, even with the two vagina. So here you can see gestational sac here on this moiety or cornu. So here I am showing you a polyp. My senior colleague has taken this picture. So on my laser, I try to adjust or edit this picture for a practice. So she took a very good picture, but I can edit a little. So I have magnified the image, changed some settings. You can see the polyp is coming from this part. This is a pedunculated polyp. So it's giving now a very good view, but never get satisfied. So you have to edit it a little. So I have magnified the image. Now, what can you do? You can change the modes. You can change the light source to give a good vibe. So I'm changing it from different angles and you can see these pictures look quite good. So the end result was like this. So if you report a picture like this, there will be no confusion for the clinician. So this was an endometrial polyp. You can also show it in a multiplanar section, and this polyp was shown like this. You can see this is a polypoid lesion coming from the endometrial wall. We can also show you the intrauterine contraceptive device like IUCD. Commonly in my country, copper T is used. So here's a picture of the copper T, which was found in the right iliac fossa. So it was displaced, not only displaced, it was perforated. Interestingly, this patient has gone through a hysterectomy for, I don't know for what purpose, but this intrauterine contraceptive device, which was displaced or perforated and located into the right iliac fossa, was not removed. Now, when the patient came to me, I found it here and I just changed it or search it with the OmniView option. You can see there is a granuloma formation here, and I have just scanned through this area, and you can see this intrauterine contraceptive device within the right iliac fossa, forming a cavity surrounding it. Okay, so we have this OmniView option, and you can see it from different angles you want. We can also use it for any other organs, like here in the thyroid gland, you can see a large nodule with a high vascularity. So you put the 3D ultrasound and you can see the nodule comes like this, or you can also demonstrate the vascularity of this nodule. So in near future, there will be some 3D demonstrations of this type of mass lesions with the vascularity assessment. So we can also try to give some angiogram-like pictures. So anyway, so that small tips. Remember that ultrasound is 3D ultrasound is a slow learning curve. So you have to explore your machine every day. Like there are so many secret options embedded there. So you just need to search for them. And always try to save the 3D and 4D pictures so that you can practice later and practice 3D in every abnormality you see in front of you and never be satisfied. We also have the elastography option where we see the elasticity or tissue stiffness, which is very important for the tumors because the tumors have hurt in nature. So we can detect the malignancy. And also it is used in hepatology as a fibroscan for detecting the hepatic tissue stiffness. And also it can be used on musculoskeletal ultrasound and in many different parts. So I'm not very happy, or maybe I'm not very expert on elastography because it's on operator dependent technique and sometimes it gives a false result. But I use it in some suspected cases, obviously. So make sure you know the limitations of elastography, which needs a very big lecture to solve. Okay, so lastly, we were going to end our session with the safety and machine orientation. So for the safety purpose, there is a very big confusion. Already I know you are confused about whether we should use the Dopplers 3D in early pregnancy, or even is it safe or unsafe to use ultrasound. So there is no documented hazard of ultrasound, but still we are uh, uh, actually searching for that. And after a long history of ultrasound, we still say that it's a safe technique. But there are some hypotheses which already got some demonstration on animals and tree. So we need to make a concern about that. So you know that here is a body tissue and we put sound over it. So some sounds got transmitted, some gets refracted, and some gets reflected. So this reflected sound is converted into image. But another thing happened, like some sounds get absorbed. Now, this is the area of concern for us. If the sounds get absorbed, then it will convert it into another energy, that is heat. So this heat can actually cause some genetic or chemical abnormalities. Now, this is the concern. Again, when we transmit a sound through a tissue, it creates some pressure, you know. So this pressure is responsible for change of some tissue. So it may cause some genetic or chemical effects also. So these are the queries which we want to solve in a patient, but fortunately, after long assessment, there is still no proven adverse effect of ultrasound in human body. We have already proved it in low class animals and trees also. There is a congenital abnormalities, postpartum, even death also. So all happen for the low class animals, but not for the human beings. So whenever there is indication, you obviously can use ultrasound. Even the Patrick, who actually invented the fetal sleep stages, he tried to do ultrasound for 50 long hours in a single patient, but there was no adverse effect. Even for my baby, I've gone through, I think, more than 28 times ultrasound, and there was no adverse effect, because I know there will be no adverse effect. So if you think that ultrasound can cause adverse effect, you should remember that even X-ray is now safe in pregnancy. But it doesn't mean that we are using X-ray all the time. We use X-ray whenever it is necessary. So we'll do ultrasound whenever it is necessary. Otherwise, we should avoid, because there are so many hazards may occur, but actually our newer machines and whatever the machine comes into the market has been checked a lot, so there is no adverse effect. If you can invent any adverse effect, then you will be given a lot of money from the manufacturers to put your mouth off, or even they may hire somebody to kill you. So that's why there is no adverse effects going on. And be sure that extremely normal to use color Doppler in early pregnancy. We use color Doppler because we want to evaluate, or we want to exclude congenital cardiac abnormalities in as early as possible. So transposition of great vessels and some other abnormalities are already can be detected before 10th week of gestational age with the help of ultrasound. So early, I have told you that early fetal echocardiography will get popular by next 10 years. So if you think that ultrasound can cause congenital abnormalities, you are living in 1980. Okay, so machine orientation. This is the machine I'm using right now. Not right now, in my chamber actually. So ultrasound machines are very different. One is different from another, and even the same manufacturer makes different type of machines. So buttons are very confusing sometimes, but you have to search for some regular button, and obviously you should explore the machine. So here is a sonocyte machine that you won't actually see commonly now. So the machine has several parts, like there is a freeze button, which we use to freeze the image or make a live image or real-time mode. There is a trackball over here, which is used as a mouse. And you know the mouse has right and left buttons. So Here we have set, select, enter type buttons. There are some measurement options like measures, caliper, stress, calculation, distance, many names. There are some modes like B, color flow. This is a Doppler enabled machine, pulse wave Doppler. It doesn't have any continuous wave Doppler. M mode, and there is any power Doppler imaging options. So there are some save options. These are included in these power buttons depending on your need. And also we have a keyboard. To activate keyboard, we need to use the ABC text annotation, something like that button. And we need the TGC. Here is the TGC option. There are several options on the screen which can be controlled by these buttons also. So there are so many buttons which we can use to our daily life simple, to make daily life simple. So here's my machine. It has a long keyboard and you can see similar buttons here. We have some buttons on the display. This is a touch enable display, and these buttons are located controllable from these functional keys. So here you can see the keyboard. To activate keyboard, I have to use this ABC option. Here's the XYZ, and you can see this is the B mode option. This is the color flow. This is the power Doppler. This is the M mode. This is the pulse Doppler. This is the B flow boyfriend option. So clicking it will not give you a boyfriend, but it will give you a very good view of blood flow. So here is a freeze option. You have some separate set, select, enter options. Saving options here. I can see a hair here. I don't know whether it's mine or someone. Okay, some power option, power on off options, and to select the probe, you can click on this button. To see the previous data, you can select archive option. You can see the report, and then there is a patient option. From here, you can enter the patient's name and every data. After finishing this patient, you can just end the examination. So here's these buttons. You just have to touch all the buttons. I saw many machines having many buttons that have never been touched. Like here is a depth changing button. You can change, just move it or change it to change the depth. And this is the focus changing button. And this is the power on off options. And there are so many other options available here. So on the screen, you will see many buttons here. There are so many dusts over there. And you can change the Doppler settings from different options. You will get different menu here. So you just need to explore all of these and to see which one is needed for you. For the trackball and surrounding options, you can see there are some settings shown here. With every preset, every mode, you will see different options here for these different keys. So this key, all the keys are shown here, and you can change whatever you want depending on which mode you are using. So thank you for all the time you have spent with me. So before finishing, I would love to share a slide that I have enjoyed on, I think, AOCR 2024 in Taipei, Taiwan. It was an excellent thyroid ablation workshop. And after that, the presenter had given me a very small message, which actually was very important. So always you should remember that if you follow the guidelines, you will remain followers. And if you dare to innovate, you'll become leaders. So all these guidelines are made if you are not able to run yourself. So you should need guidelines to run yourself, to run. But if you can run yourself, then you'll be the leader. So always see the guidelines, but don't be so much dedicated for them. Try to be the leader. Okay, so if you are from my country, we are going through some paid webinars. These are all in my local language, so these are not suitable for the foreigners. Many of you have told me to make sessions in English. My English is not very good, number one. Number two, we can arrange payment options because the payment here I take is around 4 USD, which is very cheap for a 3 hour long session with 7 days record availability. But the problem is that we have no option to refund actually. So if there is no option to refund, then I can't take money from you. So that's why we can't arrange sessions for the foreigners, because if I need to change the schedule, I need to refund you. But or if you want me to give you some refund, I won't be able to refund you because there will be a bank transaction complexity. So that's why we still can't arrange webinars for the foreign people, but hopefully there will be some free sessions. And don't forget to visit my YouTube channel also. So our YouTube channel, Imaging Study, has around 58,000 subscribers. Hopefully it will get bigger in this year or next year. And we have 461 videos. Hopefully it will get larger also. For a long time, I'm not posting any video. Hopefully I will post, at least I will try. So anyway, I have got a lot of cases that need to be posted on my YouTube channel, but I don't get any time or I'm getting lazy. Anyway, so I have got a imagingstudy.com website, and there you will get some cases. And if we have any uh, webinar related post, then you'll also can get it from there. So thank you for joining me and spending a lot of your valuable time with this session. So if you have any question, don't forget to ask on the video. So we have the live video and you can ask me any question there. Okay, yes, this is from Bangladesh. My accent is from Bangladeshi style. Okay, that is a good question about the Doppler. Can we recognize the vessel, whether it is vein or artery? We can recognize it definitely from the pulse wave Doppler actually, from the pulsations also, but not with the color. So red and blue doesn't mean this is artery, this is vein. It actually gives you an instruction about the direction of flow. So it's not about the vein or artery, because artery may look blue or red, whatever you need, you can change it also. So we can understand the artery is an artery by looking at its pulsation, looking at its wall, looking at its compressibility, and obviously it's a spectrum. Why all these points? Because if you make a fistula, then it makes a confusion, because which one is artery, which one is vein, because it gets changed. Okay, there's a question about the color flow. Like uh, you have said that sometimes people ask you about the color flow, to put the color Doppler and see whether there is a flow or not flow. It's important to adjust the color Doppler settings for this purpose. Like I give you an example. Like you see a mass lesion, like a thyroid nodule, just easy one. Like a thyroid nodule, you want to see the vascularity. If you put color Doppler, you may not see the vascularity inside that, because it has a very low velocity flow within, and your color Doppler setting need to be adjusted for that velocity. So each and every velocity flow has a separate Doppler setting. So that's why we need to change it. Like we are looking at the carotid vessel, and with that similar setting, we can't see the vertebral artery. because the vertebral artery has a low velocity. So that's why we need to change. That setting is called the PRF. Usually we also have to change the color gain, but we adjust the pulse repetition frequency. I won't go with the pulse repetition frequency now because it's very complicated or may make you very clumsy. So we reduce the PRF to see the high velocity, to see the low velocity vessel. So that's why you need to change also. Just putting color Doppler may not show you the flow. We need to a little bit adjust. And the flow is very important because if you see just a simple thing, like if you see a mass, if it has predominantly the peripheral flow, we commonly say it as a benign lesion. This is the property of benign lesion. It differs. And if you see a lesion with the prominent central flow, it usually thought as a malignant one because the malignant lesions have neovascularization at the central part. So these are important criteria we want to assess. Like if you are going through a testicular ultrasound or ovarian ultrasound, you want to see the flow because there is an enlarged ovary, there is an enlarged testis, and you are not using color flow. It indicates that you are not having the exclusion of ovarian or testicular torsions. Okay, a sad question. That we have told you that our tomorrow we have a Doppler section. I know the Doppler session about the basic physics part. Unfortunately, it's for the local people because if you can't speak in Bengali, it will be difficult to understand. And that's why we can't invite you in this session. We are just looking for the refund option. Actually, if we can manage a payment system with a refund option, then we can go for the international one. Otherwise, we will try to arrange some free sessions. Okay, so for foreigners, it's free. But for these sessions, local sessions are obviously not. Okay, so there is a question about the 3D ultrasound in arteriovenous malformation. Well, nowadays we use the Doppler ultrasound to confirm the arteriovenous malformation. Okay, uh, you can understand what the cystic area with grayscale ultrasound, then you'll use Doppler to assess the vascular flow of the arteriovenous malformation. Now, when you want to demonstrate all of this in a combination, then you can use the 3D. Especially if you are thinking about an gynecological ultrasound, you see the uterus, you see the cystic space, you see the vascularity, then you put the color Doppler. And nowadays, what we are trying to do, like you know that AVM has a arterial part and a venous part. So we try to show the 3D image that has the arterial and venous part shown on that image. But it's very difficult. Huh? So we are trying, but it's not always possible. It's possible if you use the TVS along with 3D and Doppler, then it will be easy, but not for the transabdominal one. Okay, we have recently took a penile Doppler class, and I think there will be a session if you're from the local. We have a session for the locals about the penile ultrasound, which will also cover the penile Doppler. It will be on next month, I think, because this month we don't have any schedule. Okay, Doppler will show the vascularity. Like if you think about that cyst, inside the cyst, there is only a non-flowing fluid, so it won't show. Anywhere there is a Doppler shift, you will show flow. Like Fetus is breathing, so there is a flow inside its nose, so it will show flow on Doppler. Fetus is maturating, it will show flow on Doppler. So Doppler color red or blue doesn't mean it is blood vessel. It may be any flow or any moving structure. Like I'm moving my hand. If you put Doppler here, you'll see red and blue color moving. So towards the transducer red and from the transducer blue. So you can see the flow here. So that's why the fetal movement is also showing you some colors artifacts over the screen. Now, where there is a flow, there will be a signal. But if you talk about the ovarian cyst-like thing, there is definitely, we have different classifications of URED's scoring. So we have to, clinicians usually ask us for the color scoring option, where we have to score the vascularity in a scale of 1 to 4, I think. Thyroid vascularity. Thyroid is a very vascular structure. Okay, so whenever you get a lesion, you should assess the vascularity. Though we use the thyroids for the scoring of the thyroid lesions, but there are so many disease where the Doppler is very much used. Like for the Hashimoto thyroiditis and Graves' disease differentiation, we commonly use the color Doppler. Like in case of Graves' disease, the flow is usually the peak systolic velocity of superior or inferior thyroid artery, especially we focus on the inferior thyroid artery, should be more than 70 centimeter per second. Even it may go over the 100 centimeter per second. So whereas in case of Hashimoto thyroiditis, it should be less than 70 centimeter per seconds. The normal value is usually 25 centimeter per seconds below that. And if it is more than that, we actually think it may be the area of Hashimoto thyroiditis. But there is a very important and large talk related to that. Okay, we have a plan. We have a plan. That's why, you know, it's a trial version actually. It's not a serious version. I actually started making this lecture or reorganized, because this is an old lecture of me, but I reconstructed or reorganized this session for last few hours. And definitely we'll try to arrange some sessions for the foreigners, obviously. That's why we started this. Okay, let me just check. Okay, I can only see the questions in the live section, because if I want to see all the questions from different groups, it will be difficult. So I have told you that I would love to see the questions in the live screen, so that when you are trying to see the record, you can just understand what was the question. Okay, I think we have finished. So thank you very much for joining me and giving your valuable time. If you can learn a single point from this session, that will be my success. And hopefully in near future, we'll again arrange some sessions for you so that all of us can get benefited and all our patients can get a good improved treatment and diagnosis. Thank you for being with us. Don't forget to subscribe our YouTube channel and follow us on other social platforms. Hope to see you in near future. And goodbye and good night. Thank you.